We have these are 20 questions. 20 questions now. So you have 20 minutes to resolve it. And this is self-test. This is not a test. How much you know, you will understand yourself. And subsequently, in the evening we will have post-test. The answer sheet. All the faculty may also take the sheets, except Dr. Kunchan, who is the paper setter. No, I know Dr. Kunchan will not oblige. Good morning.
मैं बाहर निकलूंगा। Last 5 minutes left.
Put up your name on the sheet so that can be identified.
Okay, time's up.
Good morning, everybody. I hope we have done with the pre-test. It was easy? Tough? So we'll start with the discussion of today, and I will be presenting about parapet poisoning. Have you seen patients of parapet poisoning LAQ in your practice? So what was the outcome of the patient? Very
I have the privilege to introduce Dr. Toxicology, Professor of Critical Care at PMC Vijay, and a key pillar for the glucose in this toxicology. Thank you.
Thank you, sir, for the kind words. And so I'll be discussing about parapet poisoning. Paraquat was discovered in 1950s and it quickly became a very popular pesticide because it is a non-selective liquid herbicide which was introduced by the British chemical company in 1962 into the market. Rapidly absorbed by the aerial parts of the plant, but it becomes inactivated when it comes in contact with the clay in the soil. It became world's largest selling weed killer. Because it is cheap, it is effective. And we must have seen OPC poisoning in our clinical practice. So it is a major clinical problem like OPC, but the problem with the paraquat is the case fatality is very high, 50 to 70%. Mainly because the compound itself is very toxic and there are no effective treatment modalities available for it. So, however, it does not have any side effects to the wildlife or environment or the health of the people spraying this. So chemically, it is a toxic bipyridal compound and owing highly potent non-selective contact herbicide, inexpensive, easily available, and because of its lethal nature, it has been banned in many countries. However, in India, it is still freely available. In Western countries, you must have a license to use paraquat, but there are no such regulations, and we are urged the government to have such regulations. It should not be freely available because anytime I will be presenting our data, at any point of time, we always have 1 or 2 patients of paraquat lying in the ICU of all age groups, from young patients to elderly, because it is available freely. India being an agricultural country, it is available in their homes easily. Yesterday there was a news that the Syngenta company has put the ban. The reasons may be others because they are linking it to Parkinson's and other movement disorders, but they have stopped making it. So it might be an effort, slowly people realize and stop. So we start with a case, a 38-year-old male who presented to the emergency department. After a heated argument, he consumed paraquat compound and he presented about 3 hours after the ingestion. Approximately amount was 30 ml, 4 to 5 episodes of vomiting, non-projectile, non-bilious, associated with generalized pain in the abdomen. His vitals seemed stable. 98 per minute was the heart rate, BP was stable, respiratory rate of 22, and he was maintaining saturation on the room air. So what is the dose which is lethal? It is about paraquat, we can say 1 sip can kill. It is available as a 20% concentrated solution. The poisoning may be intentional or accidental. About 10 to 20 ml of this paraquat poison is concentrated solution is lethal. However, there are documents of inhalation or direct contact, but they are usually not life-threatening. So toxicokinetics means what happens to the drug once it enters into the body. It is absorbed readily but very partially. Only 20% of the paraquat is absorbed by the stomach, but it rapidly gets diffused to all the organs which have high blood supply, like the lung, the liver, the kidney. It rapidly diffuses into those organs. The volume of distribution is very high, 1.6 liters per kg. The peak concentration reaches within 6 hours. It is not metabolized in the body, and 90% of the drug is excreted within 24 hours by the kidney. So initial half-life is just 6 hours. But as the toxicity develops in the kidney, the peak half-life increases and it becomes more than 4 days once the AKI sets in. So this increases the systemic exposure and worsens the toxicity. The vicious cycle starts. Paraquat causes major toxicity in the lungs and the kidney, the 2 major organs where are affected. And because in the lungs it is taken up against the concentration gradient, it is actively taken up by the pneumocystes because of the similarity to the polyamines, and therefore elimination from the lungs is still slower. So paraquat undergoes redox cycling. That is, paraquat is oxidized to paraquat monocation, and that is converted into paraquat dication inside the cell. And during this, by the action of NADPH reductase and nitrogen oxidase synthetase enzymes, this produces a superoxide radical. And this superoxide radical combines with nitric oxide to form a pernitrile oxide, which is a very strong oxidizing agent. And these free oxygen radicals and nitrate species are responsible for causing toxicity to the major organs. So in the lung there occurs, it is concentrated against the concentration gradient, it is 20 times higher than the drug found in the plasma. And it is the toxicity occurs in two phases. First is the destruction of the alveoli, and then the healing occurs by fibrosis. And fibroblasts thrive on oxygen. More the oxygen, the more will be this proliferative phase, and that is the hallmark that destroys the lung architecture, and patient slowly starts requiring increasing the level of oxygen, and that is the result of toxicity to the lung. So it is characterized by rapid excessive proliferation and differentiation of the fibroblasts, which result in lung toxicity. The AKI or renal injury can occur because of direct tubular injury, or when there is a fulminant multi-organ failure, there might be hypotension and hemodynamic instability causing AKI. And renal failure occurs early, and that is responsible. I told you the initial half-life is lesser, but once renal failure occurs, the half-life increases, and that is responsible for reduced plasma levels later on. So maintenance of renal function is the paramount importance in managing the patients of paraquat. So it is a highly corrosive substance, a caustic herbicide, that is, it can even corrode metals like aluminium and iron, and therefore when it comes in contact with the mucosal surfaces, it causes ulcerations like any other corrosive poison. So once you've seen a patient of paraquat with these oral ulcers in the mouth and the tongue, you will not forget it is called a paraquat tongue. So these appear within a few days, but they are not of prognostic significance. Even a patient who has taken paraquat and spit out, the ulcers will be present. So it doesn't carry any prognostic significance. However, there might be a generalized feeling of burning sensation or something, which are signs of systemic toxicity and are associated with mortality. So oxidative injury to the lungs and the kidney. So early deaths most occur because of the perforations, because it is a corrosive injury, or due to AKI, but the major demise is late, and the cause of which is pulmonary fibrosis. Renal failure may be oliguric or non-oliguric, and it happens within 1 or 3 days. Shock, other symptoms like stomach pain, because there can be episodes of acute hepatitis and pancreatitis, seizures or coma. So we collected that retrospective data of all poisoning cases in the institute, and to our surprise, about 1/3 of the cases were paraquat. We know that they are in high numbers, and these numbers are very scary. The data is paramount that 1/3 of the patients reporting to our institute of poisonings were of paraquat, and mainly they were the breadwinners of the family, young patients with a mean age of 28. 1/3 had rural and agricultural background, and very few patients reported early, that is within few hours. And this is the symptomatology at onset, at the time of admission. Most patients had only nausea, vomiting, and see that difficulty in breathing was only in 40%, means they present late when the pulmonary fibrosis stage comes. Mainly they came with oral ulcers when there was difficulty in swallowing, and there are other non-specific symptoms. So coming back to our patient, on examination, the patient he was oriented to time place. There is no problem with the GCS. He is conscious oriented, but he is having distress because of the oral ulcerations, difficulty in food swallowing. All the initial chest X-ray was normal. All the lab investigations were normal, except that he had a high lactate. So this is a typical picture of the paraquat tongue oral ulcerations which appear, but it takes time. So how do you diagnose? In this patient, we had a clear history of something in ingestion of the paraquat sometimes. Sometimes they do not bring a typical history, and the differential diagnosis is any other corrosive poisoning. But in other corrosive poisonings, the clue is that usually the general systemic issues are not there, the other organ involvements. Unexplained renal failure with progressive hypoxia, and by the time you see hypoxia, oral ulcerations, so the history comes out itself, and then you probe, you get the history. But the clinical, and if you are doubting, the urinary diathymic test is of paramount importance. So it is a bedside, simple, semi-quantitative test that in the alkaline medium, if you can do it with urine or with plasma, in the alkaline medium you add sodium hydroxide, it becomes alkaline. Sodium diethionate will change paraquat into paraquat monocation, which is blue in color. And this is semi-quantitative because from the color you can have an idea. The higher the concentration, the darker will be the color it is. So in very high concentration, if it is being taken, it will be black. It is blue if it is paraquat, it is green if it is diquat. So urine paraquat concentration more than 1 milligram per liter or plasma paraquat more than 2 milligram per liter are the concentrations if the patient, the test turns blue, darker the color, more the concentration, and it has a prognostic significance. That is, patients are high mortality if the test is positive, but if the test is negative, then the chances of survival are high. So this was the test of our patient. Our case, it was highly, patient had taken a large amount. So these are, if the plasma value is available, so these are the Proudfoot curves which are available to tell us about the predictive probability. Like if the patient has a concentration 1 microgram at 8 hours after injection, there is high survival is unlikely, but if the concentration is low after 12 hours, the probability is so. But the problem with this is that the plasma levels are not easily available and available everywhere. So another which is also in literature, the severity index of paraquat poisoning, the SIPP score. It is the best predictive of survival in self-poisoning. So it is calculated by the time difference between the ingestion and proper treatment. The time multiplied by the plasma concentration. So if SIPP score is less than 10, survival is unlikely. So it is helps us in telling the survival estimates, but the challenge is the imprecise time of exposure, and the paraquat assay is not available at all places within the time frame. So when it is not available, how do we assess the survival? What is there in our clinical? So higher the age, the greater the clinical severity, that is high respiratory rate, high WBC count, the rate of rise of creatinine is very helpful in determining the outcome of the patient. Similarly, the higher lactate levels. So if the rate of rise of creatinine is slow, the patient is likely to survive, but if it is higher, more than 0.5 per hour, then it is the patient is likely to die. Or if available, the levels of cystatin C are also helpful in predicting the outcome of the patient. So this is the data which we have published, and with me, the lead author was Dr. Shruti. She was there with me in the audience. So we published our work on the paraquat poisoning. I told you 100 patients we received in 1 year, and only the documentation of the amount was possible only in 20 patients, and this was not related to mortality. And we tried to compare the time lag to presentation of hospital to the outcome. So only, you can see the blue ones are the patients who are the survivors, the time period is less. 60% of the patients who presented after 24 hours had a poor outcome. The shortest time to presentation was as early as half an hour, and the largest maximum time 19 days. So only when they have problems in breathing, they report to the hospital sometimes. So comparison of all the laboratory parameters and the signs and symptoms between the survivors and non-survivors, you can see high respiratory rate, low bicarb level, high lactates, deranged RFTs and LFTs, and the higher WBC count. All these were significantly different between the survivors and the non-survivors. So we know paraquat does not have an antidote extrapolated from small observational trials, and these trials have few patients. There are methodological problems and analytical errors. So even the mortality in best centers is about 70%. So the goals of treatment remain symptomatic, supportive, a combination of the preventive and treatment strategies. So because it immediately gets inactivated by coming in contact with soil, so activated charcoal or Fuller's earth has been recommended, but by the time the patients reach us, they have already lost the time we can do contamination. So largely avoid oxygen and palliative care for those patients who are in terminal decline. So as we say ABC, you have to ensure airway, breathing and circulation. Airway is mainly patent. Breathing is also fine. Do not provide oxygen. While circulation, it is important to maintain the renal functions which are of paramount importance. So give fluids, keep the patient hydrated because he is going to develop ulcers and that is going to cause loss from the mucosa. Although the patient also will be NPO because there will be corrosions and ulcerative lesions, but when you give fluid, it should be in the back of mind. Patient is going to develop AKI, has a high likelihood. So closely watch. The patient should not go into fluid overload and watch for the electrolytes as well. symptomatic treatment for vomiting and the pain from oral ulcers. Again, putting in a Ryle's tube is a double-edged sword. Very early you might put, but once the patient develops lesions, it is challenging. Patient might develop perforation. On the other hand, you want to feed the patient also early because the patient is going to have mucosal ulcerations and not going to take orally. But routine endoscopy and putting the Ryle's tube is also not preferred. So our patient, we managed him with fluids, with symptomatic treatment. He came early, we put in an NG tube, started feeds. On the third day, he started having decreased urine output and serum creatinine started increasing. 2 days later, he had shortness of breath, and by the day 5, the patient was on NIV requirement. So this was the X-ray. The initial X-ray was normal. So this was the X-ray by day 5. So it is, the probability is high that it is due to direct injury, but there might be risk of aspiration or infections have to be ruled out, and antibiotics in poisoning patients are given only if you suspect infections. So, and this was a CT which was done on day 12, which showed the reticulointerstitial changes, means the patient is developing pulmonary fibrosis. So characteristically, the clinical signs and symptoms depend upon the dose ingested. Many times, if the dose ingested is very less than 20 milligrams per kg, it is mild or subacute, or we say it is asymptomatic poisoning, and these patients are the only ones which are lucky to have a complete recovery. However, if the dose is high, most of the patients land up into fulminant hyperacute poisoning, where there is multi-organ failure and involvement of all organs, hepatic involvement, GI ulcerations, myocarditis, profound shock, coma and death. So multi-organ failure and death occurs early. But majority of the patients fall in this category. If they come early, your resuscitative efforts might. But again, I will say that because we don't have an antidote, we don't have, it is only resuscitation and supportive care, still the best centers will have 80%, 7 to 80% mortality. So here, within hours, the patient will not have any symptoms. Slowly, renal failure might develop, although it is not the never the cause of demise. The liver or renal involvement do not cause death of the patient. It is only pulmonary fibrosis and respiratory hypoxia which leads to death in about a few weeks' time. So hemodialysis is done for all indications in routine patients, that is if they have acidosis, fluid overload, electrolyte disturbances, oliguria, but it is not effective in enhancing paraquat removal from the body. Hemoperfusion, it is the first and the earliest modality for removing the poison from the body. So hemoperfusion done with charcoal filters, which are now available from HA320, may remove charcoal, but it is helpful only if done early. And when the probability of survival is within 20 to 70%, means if it is less than 20%, there is no effect. The probability is more than 70%, then also it will not help. So in between 20 to 70%, if it is the probability of survival, so any small difference of decrease in the plasma level might change the outcome of the patient. So must, if you have the availability and the survival is about even 50%, I think if you have the availability, you should go in for this hemoperfusion. Although there is no evidence that continuous hemoperfusion and hemofiltration are life-saving, but they prolong the life and allow the use of other modalities which may be life-saving. So why it is so, within the time frame of 4 to 6 hours, it must be done. Because as I told, 90% of the paraquat which is absorbed is excreted by the kidney in 6 hours, the half-life is 6 hours. And the time frame window, you can see if this here the dialysis has been performed later after 4 hours. This red line is the level in the lung and the blue is in dotted line is in the tissues. The level don't decrease. Only performed started very early, within 2 to 4 hours. The concentration in the lungs slightly decreases and it changes. So the time frame where it is the hemoperfusion is effective is also very short. So people have used up to 7 sessions and of 6 to 8 durations each of hemoperfusion and showed slight improvement in their outcomes. Because it is a highly, the oxygen radicals are the main pathophysiological mechanisms. So people have tried as a desperate method when there is nothing. So let us try all what is available. Anti-inflammatory, immunosuppressive therapies in the form of steroid pulse, cyclophosphamide, NAC therapy, salicylate, vitamin E, C, dexporophene, but they are all under research and no one has, no definitive therapy has shown to decrease lung injury or fibrosis once it starts developing. So this is the evidence. There are many studies, but the results are not very conclusive. A large Cochrane review also showed that is 4 studies on 400 people, 2 from China, 1 from Iran and Sri Lanka. They gave the participants cyclophosphamide with methylprednisolone or dexamethasone, but no difference. Although it changed the hospital survival, but there was no difference in the number of deaths 3 months later. So in our patient, we did hemodiopsin for 2 sessions. Then the patient could not afford it. They're from poor families, and only 2 sessions were done. We started with cyclophosphamide, methylprednisolone, pulse followed by dexamethasone and also vitamin C. But unfortunately, the renal failure continued. The patient continued to deteriorate, and desaturation continued, and need for mechanical ventilation was explained. But the patient went against medical advice on day 6. So in our series of 100 patients, about 80% patients had a higher creatinine or developed AKI, but they were non-oliguric in many patients, and only 25% patients required renal replacement therapy in the form of SLED or intermittent hemodialysis. Most of our patients presented late, that is after 4 hours, and only 12 were within the window that we could do hemoperfusion, and out of which only 4 patients survived. So the duration of presentation, the lactate levels and the hemoperfusion were significantly associated with survival. Other newer therapies have been tried, like a free radical scavenger antioxidant, which is edaravone, anti-C5a antibodies, which is anti-inflammatory, and even lung irradiation have been tried as desperate measures. Extracorporeal therapy, it is available, and in a patient of paraquat, it must be given only and only if it is a bridge to transplant. You're preparing the patient for lung transplant, then it might be helpful. There is only one study which has shown combined continuous veno-venous hemofiltration and hemoperfusion that it improved outcomes. But like in Hyderabad, they are doing the lung transplant has been done for 3-4 patients of paraquat poisoning, and 2 years till now, 2 years have passed and the patients are okay. But there are episodes or documents that it can reoccur in the allograft transplanted lung also. So it is quite a challenge. So I end with saying that the clinical cause for paraquat are: do not supplement oxygen because it leads, unless there is serious hypoxia. Palliative measures for patients who are in terminal decline. You see the renal series of creatinine, if it is rising very high, the probability of survival because the plasma levels are not there. Urinary diethionate test is easy and easily available. If you have the provision, do that to confirm your diagnosis. If you have the provision of hemoperfusion and the patient has a 50% chance of survival, do hemoperfusion. Keep on doing it till the urinary diethionate test is negative. You can repeat the sessions. Rise in creatinine, rise in hepatic enzymes does not affect the outcome. Renal injury, if it is non-oliguric, will resolve in a couple of weeks. It is not the cause of death in many patients. Pulmonary fibrosis is most common cause of demise, and prognosis is usually obtained by initial days by the rate of renal failure. Thank you.
I have a couple of Dr. Gunjan, probably your exposure to paraquat poisoning is highest in the country. As whatever I understand, whatever literature I have gone through, and you said at any given time you have 1 or 2 cases, there's very high incidence in your center, and you have the maximum chance of looking after how can you save these patients. Couple of things. Now you have related survival of these patients to plasma levels, initial plasma levels, probable initial plasma levels. Why did you not try TP, total plasma exchange, on say day 2 or day 1 itself? Because the absorption, either whatever absorption, it is very, very fast and it is degraded very, very fast. So, what was the reason that you have not thought of total plasma exchange? If only plasma level is so important to the survival, ultimate survival of the patient. And if you combine total plasma exchange with hemoperfusion, what are your thoughts about it?
So it might be an option, I'm not sure about it, but then the plasma levels have been heme absorption when it is available with us, we tried that because the blood
Heme absorption is at different level.
Yes.
And plasma exchange is prior to heme absorption.
But the problem prior to this kind of problem, sir, the patients come very late. They are already coming, I told you, patients come after 12, 24 hours. So there is no document on this that removal from plasma at that point of time might be helpful. So that is not.
Do you think it's worthwhile?
Maybe we have to look up there.
But we have committed that plasma levels are important. Triethylene test will be positive only if it is in plasma. If it is deposited in tissues, right. So once it is showing highly positive and your color of urine is so dark, so is that an appropriate time to think about TB? No, that's it. No, I am only relating to that probably significant amount of parapet is present in plasma. I am just relating from whatever we understand. Because we don't get many cases of parapet because I think this is rich farmers use parapet. Though it may be cheap, but cotton farmers use it, most of it. That's what I understand, I may be wrong. And whatever parapet we get, we send them. We don't accept them because we think that it's a hopeless exercise. Right. So and let them go to a center who deals with parapet poisoning. So I am suggesting that could you think of, explore possibility of PPE, don't give away hemoabsorption. If you could do PPE on day 1 or 2 itself, combined with hemoabsorption. Can we try? Theory has one place and website practices maybe because we have to do it and try. Number one. Number two, I saw that you have used DNS in place of NS. Any particular reasons? We usually use NS.
Because sir, by the time the patient comes, we were not sure we will be able to put in RT and field first we started, so we started with it. Otherwise, there is no reason. We also give NS for resuscitation.
Right. Number 3, lactic acidosis is not a problem. You showed. None of the cases showed lactic acid beyond.
Not very high.
All below 5.
Yes,
Most
sir.
of them below 5, so it's not a problem.
Not big problem.
So acidosis, whatever.
Few patients who develop liver failure also in those patients.
That's because of liver failure.
The primary problem is not acidosis.
Now,
It is mostly preserved. Many.
last question. What is the ethical stand as far as your group is concerned, referring these cases for transplant? Ethical stand. You have said that there is high chance of, whatever I know, there is high chance of recurrence in the transplanted lung.
Sir, we have not explored the option of we don't send patients for transplant.
No, I am saying, what is your ethical stand? Would you, if you are the authority, would you send these patients, suggest them to go for lung transplant?
So it is a very challenging situation, high risk of recurrence in transplant. Although documents from our colleagues only, the ones who are doing in Hyderabad, they have sent 2 cases and they are fine 2 years later.
No, you
So
see,
but we find
those who do it, they may be quite excited for several reasons.
we we are not referring to give them
First, we
option
have to
that
put
is.
them on acne, sir, and if they survive, if they are healthy, the lung is open.
No, that's if you want to go for transplant, then you will do everything possible to keep them alive.
We are not giving it as an option.
So you think that should be not be done, or you just, it's an administrative decision?
Not an administrative, sir, the patient is never affording.
Okay, affordable.
They are never affording, they take the.
The literature says regarding the plasmapheresis, the volume distribution, rapid volume distribution in paracut poisoning is very high. That's why initially we are not using very less amount of poison extract by this therapy. So after that, once the cytokinins are released in the blood, then there is a role of plasma therapy, but initially there is no role of plasmapheresis in this paracut.
No, I am saying, we are saying so before trying it out. Only on theoretical discussion. I am suggesting that is there any room for considering it and trying it out? Because the mortality is very high. Why not do something which probably sounds little an option available.
You have also tried charcoal for
Yes, yes. Whatever hemoglobin is charcoal.
that is working well or
Not working well. The only problem is patients come referred are late. Only those 3 patients, out of 100 patients, 8, 12 came, 8 we tried the whole circuit. So you want to, charcoal is the only reason, or there are options we offer. But whatever desperate efforts, but once we come to know the patient has within 24 hours, we shift it to the ICU, and then the effort is to start as early as possible, because of that is the only document.
And the most of that session is the lung patients. Can we try antifibrotic drugs to prevent this? Because they were tried doing
They have been tried, everything has been tried, but the significant evidence that they will change the outcome, that is why we said, we also gave cyclophosphamide and cyclophosphamide, but the outcome still not, the documented, the long-term survival is not.
Thank you, Gunjan, and everyone for the participation. We'll move to a very different topic regarding industrial toxicity, industrial poisoning, and for that, we have the best person in country with us, Mr. Jadoti, who is an industrial toxicologist. He works with the industries as well as government of Gujarat, and other governments also take him as consultant. So over to you, Tejas.
So thank you so much. I would like to extend my greatest thanks to Dr. Rita sir for inviting me here in front of all of you, and also the Swami Vivekanand Charitable Hospitals for inviting me here. And since yesterday I was here, I was very much impressed the way the hospital is running here over, and very punctual staff. And yesterday we have seen all the facilities in the hospitals, and we were very much impressed with this kind of a charitable trust in them, and they are working like this. So congratulations to all of you. So good morning all of you, and my session, as I told you, that this is an industrial chemical toxicity point of view. So we all know that toxicokinetics is not like rocket science, right? If you really want to understand, because in industries where we are doing or dealing with this kind of chemicals. So many times what will happen that if the person have committed suicide and he comes to the casualty, that we know that the person will tell you some history, that yes, I have consumed these, or may not be telling you the history. He pata nahi kya hua, kya kaise hua. In industries is altogether different scenarios. Because whenever that is chemical sectors, we are working with the employees, contract workers, permanent employees. They are working in the sites. And many times I just give you 1 week back, I had one patient or one worker in the industry, and he found unconscious at the site while working. He was having a full air pressure suits, and he had done a proper preventive measures by working with this kind of chemicals. So when he was taken, because in the industries we are having an occupational health center, that's known as ONC. We are having a factory medical officers in the ONC. We are having a nursing staff also in the ONC. So these are all the requirements as per the factory act. They must have to remain 24/7. So when that person taken to the hospital or the ONC, the doctor asked, because most of the time in the occupational health center, they have most important thing, they have to rule out the occupational experts. Then the non-occupational thing that will comes into their minds. So he was just asking कि क्या हुआ, कैसे काम कर रहा था, कहाँ पे काम कर रहा था. So history was given from the colleagues. कैसे यहाँ पे काम कर रहा था and become unconscious. After that, all the entire parameters were in check, the basic parameters at the ONC level, and it was altogether near normals. It is the oxygen level was around 90, 92, but otherwise hemodynamically stable. But he was in altered sensory. So the doctor was ruled out again, the hypoglycemia, the blood pressure, and all these things, the primary level. But immediately some person came from the industry and he told that, sir, वो H2S exposure था ऐसा लग रहा है. Now H2S is somewhat like hydrogen sulfide. In the industrial setup, H2S is quite dangerous or any other setups. We all know that whenever that we have our main own workers goes inside the cleanup करने के लिए जाते हैं and they become unconscious and maybe later on die. What may be the reason? Anyone knows? They died with the carbon monoxide. Methane? No, they are dying with the H2S because of the decomposition gas. And we never know that the H2S is such a dangerous compound. So H2S, जब वो exposure किया तो हमारे doctors trained that we, and most of the important thing in H2S is we have to give anti-cyanide heat as an antidote. Because sulfhemoglobin must have to be converted to normal oxyhemoglobin, and we have to give the amine nitrate from the eliminations form pre-hospital use. So the doctor had started giving the amyl nitrate, the patient after that referred to the hospital to take nearby, and the person became conscious till that time, his hemodynamically stable and all these things were all right. And the treating physician was a critical care specialist in that particular hospital, and he was asking कि क्या हुआ, and he was also telling कि H2S exposure, he Googled it, कि H2S क्या होता है, कैसे होता है, तो उन्होंने भी देखा कि इसमें ये सारी चीजें होती हैं. Now the patient was that the patient is stable, hemodynamically stable, fully conscious, no other any complaints, all the parameters are the normal conditions. But now the doctor has decided that he wants to give an entire kit to this patient. That means a sodium thiosulfate and sodium nitrate of the anti-cyanide kits. Now the patient was that whether that we should give this kit or not. Because the patient is conscious, fully oriented, the factory medical officer was also in dilemma that the doctor whether should be give or not. And after that, during that time, someone again called from the industry that it was not an H2S exit. So now entire system is going to be different now. So industrial setups, if you really want to work, you have to be very, very careful that what are the features, what are the things that you have to look after. And problem what that guy was, he was having an air pressure suit. उसमें ऑक्सीजन का एक कनेक्शन होता है पाइप का, पूरा एयर प्रेशर सूट में जब हम लोग काम करते हैं इंडस्ट्रीज में. So he connected nitrogen pipe with that, rather other than the oxygen. So it was nitrogen toxicity. It was not at all related to the H2S. So many times in industrial exposures that may be acute one or the chronic one, that's a really challenging compared to the routine day-to-day exposures. Because in day-to-day exposures we are getting clues, we are getting many a times history, we are getting many a times containers, or the empty strips. But in industrial setups again, maybe a mixture of chemicals, whatever that industries are manufacturing. Many times the industries are also using intermediates, like what we are having a Bhopal case. The methyl isocyanide was an intermediate. And most of the time the industries, intermediates का कोई information नहीं होता. Industry के पास. उसका MS TSP नहीं होता. That's the material safety data sheets. So उस time पे doctors के लिए बहुत difficult हो जाता है कि how to manage this kind of patients when we don't have any kind of information. Because most of the industries they are having monopolies for hiding their intermediate process point of view. So we have to understand absorption distributions and eliminations. Important thing is that if someone have exposed, how much exposed, kitna exposed, we all know toxicology is not going to detail of all these things. But the important point of view from the industrial perspective point of view, we have to understand this substance. Substance may be anything, may be a mixture of substance that depends on many acute or chronic exposures. But as I told you, all the substances are poisonous. There is none which is not poisonous. The right dose will differentiate. That may be a possibility. I will just touch upon the few of the examples, and use of chemicals are not newer things nowadays. They have been used in non-traditional methods since 5th centuries. 19th centuries also, the arsenic had been used in British bottles. This is also poison cloud being generated. So chemical, biological, nuclear and other agents been still used since many years. If you're going to talk about the chemical agents, that may be a blistering agents or vesicles, pulmonary or choking agents, cellular asphyxiants of blood, nerve agents, incapacitants, there are many. Blistering agents, that may be herbicide, phosgene, oximes. Here the phosgene is a little bit different. I will just come to that. There may be irritations, onset to beginnings, but we'll come to that. So various accidents due to the consequences are well known and gives a prominent portions to prepare, practice and amend our toxic disaster management plan. And that is very, very important for each and every district, or each and every, you can say, industry. As per the Amendment Factory Act, each chemical industry has to prepare this kind of a plan on-site and off-site and submit to the chief inspector of factories for the boilers that have to work. But important thing is organizations worldwide have learned this importance of applying these principles in a hard way. Because we are just waiting for any incident to happen. They are not concerned about the preventive aspects. So therefore the prevention, protections and separation techniques must have to be applied to reduce the probability of this kind of disasters. We all know Bhopal gas pressure, the Union Carbide plants, where the methyl isocyanate was an intermediate used in the process, and there were many people died. Was disaster, 2,000 people died, more than 13,000 died in the next many years. Many people suffering from cancer, partial blindness, stress disorder, menstrual irregularities, abortions, and many things. How it happened? Because of the safety system was not worked well, accidental release of methyl isocyanate. The most important thing in this kind of a disaster is community awareness. Community was not at all prepared and aware that what kind of chemicals been used in this kind of industries. So they have been found themselves, totally uninformed, and they created chaos. So this was the picture of most of the people killed or died in this kind of a closed plant. So from this kind of plant out disaster, we learned that reduce the inventory of the hazardous material, keep all the safety related equipment in order, residential areas away from the plant, and proper management. Another important example, if you can see Flexible UK, where their company's name is Nipro Limited, they are using cyclohexane. I will just come to this. If you can see this, this is a 5th one reactor, and it was little bit of damage. And as the cyclohexane is quite explosive compound, and the dogleg pipe, this was operated for many months, and huge volume of reactants and produce that create a massive explosion, and many people died and many people have suffered from this kind of injuries also. So what are the major chemical disasters that may, triangle factory fire in New York, Minamata mercury disasters in Japan, Sivoso dioxin disasters, Bhopal gas disasters, Sriram gas leak, chemical terrorist events also that can happen, 1985 since today. These are the examples of, you can see the major toxic releases. Phosgene, again, here the phosgene is quite different from the phosphine what we are treating. So many times what will happen that patients come from the industries and they are telling that's a phosgene का exposure हुआ है. तो हम लोग phosphine को consider करते हैं, that's a phosgene, it is not phosphine. Chlorine, dioxin, ammonia, many LPG, many methyl, dimethyl ether, kerosene, These are all the industrial explosions that may happen. The important questions that I just want to ask all of you that whether this kind of a disaster situations happen to any other part of the Indian populations and whether we are prepared as a medical team or not. Whether we know that what to do in this because few years back in one of my where I'm working on an industry as a toxicologist that one of the cyanide explosions nearby Pune and almost more than 200 workers were affected and it was a place called Nida. So we have only one hospital where the two ventilators were available. What to do, when to do, what kind of a transport that because that will be taking 3-4 hours transportation from Nida to Pune. And whether we got our ICU on wheels or not, how to transfer the patients. Most importantly at the time, what are the important decontaminations, the procedure for decontamination rules. Anyone knows that? Any hospital have decontamination rules. Because many times what happened in Ahmedabad, sir, we are having one patient and our resident doctor was there in the government hospital and that patient was having severe breathing issues and respiratory gasping that he was admitted and he was about to put the tubes on ventilator. And suddenly that is a bleeding coming from the throat or something and flash on the mouth of the resident. And after that what happened? That person was diagnosed later on the CCHF, criminal hemorrhagic fever, and he died and the resident doctor also died. Due to the virus was transferred from the blood to the cornea of the residents. So we never thought of putting even safety goggles while intubating the patients. So there are many occupational hazards that we don't know and most importantly whenever that we are dealing with the chemicals. One of the doctor in Gujarat and he is very treating many organ of phosphorus poisoning in the rural setup. And his home is and clinic home are both on the same building. So he used to go to see the patients frequently and anyone have committed suicide, the chemical was there on the clothes. He don't have the facilities to change the clothes or the decontamination. So वही कपड़े पहने रहते हैं. जब भी आप उनके ICU में जाए, ward में जाए, you can smell pesticides or insecticides पूरा भरा रहता है. The outcome of that doctor is very well. That patients recovered very well. But what happened to that doctor after 5 years of extensive practice of this kind of poisoning treatment? He himself developed organophosphate-induced delayed neuropathy. Only from the inhalation of this patient's treatment. So you can imagine that many times we never know that whether we are prepared for this kind of activities or not. If you're talking about the chemical accidents that maybe in industrial transportation is again a big issue. We know that there are many tankers, maybe hundreds of thousands of tankers being transported every day. Chlorine is the most highly transported chemicals in India. So whether it is on roads, whether it is on planes, and if anything happens, leak or accident and the entire chemical is poured on the sides, road sides, then how will you manage it? How will you make the spillage controlled? Because that might be the people who are just going, they may be affected. So that's again a big issue. So we have to understand in the industries the different kinds of chemical categories, whether it is acid, base, flammable, oxidizer, pyrophoric, flax, sensitive, or carcinogens. Because there are many chemicals used in the industries that have got CMR properties, that is a carcinogenic, mutagenic, and nephrotoxic properties. And these are very important for understanding in, if you can say that, for the chronic exposures point of view. So that's why from the industrial exposure, the chronic, you have to also understand the biological monitoring. Where you have to say that which are the metabolites must have to be seen. Just for example, if the person is working in benzene related products, I want to see the urine phenol or butyric acid of the metabolites into the urine of that particular person. If that is going to be high, I immediately tell that workers must have to be relocated from the benzene related products. Because it is a high time, because otherwise that is going to be affected his bone marrow or the blood and he may be a case of cancer in the near future. So, major chemical exposures may be asphyxiants, cholinesterase, respiratory tract irritants, corrosive and vesicants. We have to make on-site and off-site emergency plan. We have to make first responders requirements. which must have to be understand what hazardous materials are into the industries. Risk of the hazardous material, they must have to understand the outcomes, release, and if possible, determine the need for the additional resources. And the first responders categories, capacities like important thing is in the emergency and this kind of a situation, whom we are going to ask is very important. Because if someone have no knowledge about this kind of an industrial exposure, they may have got limited knowledge, they may not be able to guide it properly. If I am going to say about the asphyxiants, simple and chemical, but the important one here is the carbon monoxide, cyanide and hydrogen sulfide. As I told you, this asphyxiants required this anti-cyanide kit. So this is a cyanide antidote kit which is going to be manufactured by the Troika on demand. So this kind of a kits you can get it in emergency. Here what we are dealing in the industrial point of view, here this is amyl nitrate first. Here if you can see both the sides are cotton and in between this is a plastic cover. In between we are having this glass and or the covering. So what we have to do, recently we have one incident in Lote, that is Bombay Goa highway, where we have this acetonitrile exposure in one of the industry and we just advised that so 10 to 12 people were affected. We just advised our nursing staff to give this amyl nitrate and he was a very experienced nursing staff. He knows that each and every emergencies. He gave all these things to the workers and they were all right. But what happened, what went wrong to this? Because here we already trained them कि आपको ये cotton को निकालना नहीं है. So what he did, he removed the cotton, removed its glass and fuel from this plastic covering, and after that he broke down into the cotton, that material, and after that this is a route of administration for this amyl nitrate is inhalation, through inhalation. So उसने फिर क्या किया, ये cotton को workers के सामने नाक के आगे रख दिया और they will start the shifting. But again, he himself was not wearing any kind of a mask or something. So he himself was also inhaling amyl nitrate continuously. So he developed cyanosis. So we have to not worry about that particular workers, but he himself was admitted for the low oxygen level. Actually, this knot has to be removed. Actually, ये covering इसीलिए दिया हुआ because the route of administration is inhalation, so quite strong water. So you just have to press over this plastic covering, so वो अंदर ही टूट जाए और फिर उसका जो भी कुछ liquid material है वो यहाँ पे cotton में आ जाए. So you have to just put this cotton like this on with the help of plastic covering, so that the person will inhale and they will reach to the hospital. And after that we have to give access for the need, the sodium nitrate and sodium thiosulfate. यहाँ पे मिथिलिन ब्लू भी हम लोग पहले देते थे because if some person have got a more high hemoglobin, then you have to give that also. Another very important scenario is respiratory tract irritants from the industrial point of view, where we have to understand whether these chemicals are highly soluble in water or not. The solubility in water. So if you don't remember each and every chemicals exposures, you just remember and you can ask the industry people whether there is a solubility in water or not. If it is a highly soluble, mostly like ammonia, formaldehyde, hydrogen chloride, sulfur dioxide, will be affecting your upper respiratory, eye, nose and throat. But if it is moderate to strangely soluble like chlorine or phosgene or nitrogen dioxide, that will go directly and that affected pulmonary edema also. Like in the phosgene case, the phosgene is such an toxic kind of a gas release. Many times what will happen that the person may have got problems in industrial setup. Most of the time the people may have got exposure and after that almost 24 to 48 hours के बाद में उनको सब toxicity start. So you have to be a latent period and during that latency period if the worker is not going to come back like in phosgene, then that will be a problem. Because we have seen many patients who have to put on ECMO also with the phosgene exposures. So this is the respiratory tract irritants point of view. There are also corrosives, we will not go into detail because corrosives has already been covered. Only one chemical that's very important, hydrofluoric acid, that you just have to remember whenever that if any person has this HF exposure. Because what will happen, I'll just give you one of the example of HF because that's been this kind of chemicals been highly used in different industries where the chemical just pour on the skin and skin के through पूरा systematic circulations को damage करे. So the workers may not tell you if they are being affected. So suppose HF exposure हो गया, so they will go back to the home. They don't have a problem till that time. But after that, they will have severe pain. And if you were to see that this fluoride ions have got a high affinity for the calcium and magnesium, and this may lead to the hypocalcemia, hypercalcemia, or hyperkalemia. So the persons may have particular ECG arrhythmia changes also. So that's why this kind of chemicals are very important. May lead to severe neuropathic pain, muscle twitching, TGD, marked irritability, maybe a prolonged QT interval. So if you are a doctor, emergency physician, or factory medical officer, if you are not taken care of this, you may miss the patients and later on the patient may not survive. So in that case, we have to act immediately with the calciums. We have to give the calcium gluconate, maybe intraocular or the cases electrolyte poison that we have to give the in titrated dose to control this arrhythmias and hypocalcemia and hypomagnesemia. Another important group is hydrocarbons and halogenated hydrocarbons. We'll not go into detail because these are all the CNS depletions. We just provide the supportive treatment. Another very important group is acute methemoglobinemia. There are many patients who come with this kind of cyanosis. There are so many compounds, if you can see, they can cause cyanosis, different chemicals. Even some of the medicines also, like pepsones and quinine or chloroquine, issues. So, this is a methemoglobin label. If the facility is available, then you have to go for the methemoglobin label and treat these patients for the methemoglobinemia. Important antidote is here the methylene blue. But important thing is methylene blue should be available. Many times even methylene blue is not available. So methylene blue. Important another thing is that 1 ampule or 2 ampule is fair enough for any kind of methemoglobinemia. If your patient is not responded to 2 or 3 ampules, then you have to change your diagnosis. Maybe have some J6PD deficiency or methemoglobin reductase enzyme deficiency or any other issues. Many times we have seen that the patients have been given 50 ampules of methylene. So that is also we have to be very careful. And so the general measures that we have to act in coordinated manner. We have to inform employees, provide training, and this kind of an MSTS you can ask for the industries, where all the information regarding the chemicals being available. MS, there is a material safety data sheet. You can have pre-hospital use of antidotes, or cyanide antidote kit. We have got this kind of a detection kits at the sites, proper decontaminations, personal protective equipments. So in short, we have to aware, alert and alive. Don't buy or store the chemicals that don't need. Recently, we have got one incident. Throw some of the unnecessary chemicals that may be required in hospital for some reasons, maybe a pathology or something. They require some small quantity of chemical, and they have got a RTPH inspection. तो उनको लगा ये तो अभी ये लोग देख लेंगे, पूछेंगे ये किधर से आया कैसे आया, तो उन्होंने फीमेल वॉशरूम में जाके डिस्कार्ड कर दिया, because they were thinking कि फीमेल वॉशरूम में बहुत ज़्यादा कुछ आएगा नहीं, and they closed in that washroom, and after that one female went inside, became unconscious, and she was brought dead actually to the emergency. So many times the chemical have some different kind of reactions. If you don't know and if you are discarded it like that, it will again comes to us only. And store the chemicals in the original containers only that wear the proper PPEs, always dispose the chemicals safely. That's very important. Gujarat industry में ऐसा हुआ था कि जहाँ पे they have disposed the chemicals on the roadside illegally. So the 7 workers, 7 people were just sleeping beside the roads. They found dead on the next morning. So if you were to discard this kind of chemicals which is very toxic or without having any treatment, then that will be a problem to the zombie. So there are different antidotes must have to be kept at the industries level only. I will just at the end I will just show you one of the photographs of one of the. If you can see, this is the hand of one of the patient recently been X-ray उसका हाथ में swelling था wrist पे, तो X-ray करवाया. Can anyone recognize what is all this thing? मरकरी हाथ के अंदर. You can see this. smaller. Mercury. तो mercury अंदर subcutaneous tissues में भी है. जब हमने ये you can see here. You can see his lungs. Mercury. ये जो mercury निकाला है वो pellets kind of a mercury. उसका lungs भी देखा है. उसका CT scan भी करवाया था. हर एक जगह. He is like a mercury man. So he is a 24-year-old boy and he was having this exposure source उसका दो जगह पे था. जब हमने उसको ट्रीट किया, it's a very high mercury level blood and urine flow, and he was taking he was very fond of fish, so he was taking fish morning, afternoon, lunch or dinner maybe. But वो जो जगह पे रहता था इंदौर में, तो जहाँ से वो फिश आता था वहाँ पे इंडस्ट्री का एफ्लुएंट बहुत ज़्यादा ऐसे ही डिस्कार्ड करता. So that fish was eating that effluents and ultimately that boy was eating that similar fish for many months. Another was positive history for this boy was he was having e-cigarette smoke and he was 1,000 puffs in a day. He was believing that e-cigarette is not harmful, even though his name was Sanskar. So, and in his entire family, everyone was a doctor. So they were all tried animal ways to remove this mercury, and after that we have started the succimer, and we can able to control few of the things. And still the boy is doing good, but that may be the case. There are many cases been coming from a different kind of an exposure. And the last one is here also. This is the one lady came.
Other people in the community consuming the same fish.
Maybe they may be consuming the same fish, but that might be the possibility that he was having a staple diet for many months, the same things. Maybe other people are not having that much of craving for this kind of eating fish. That may be the reasons. This lady came to us with this kind of a lesions with the pinkish color, hands and the face and all, and she was starting with the pedal edema. And she was a young 32-year-old lady and not having anything history positive, so they just went to the physician and physician asked for the nephrologist opinion. The nephrologist also found nothing, but there's a little bit of albumin was there positive for the urine, and after that they just got for the kidney biopsy, and she was found positive for the membranous nephropathy. So membranous nephropathy was there, but what was the cause they didn't rule out. Or because in the adults that is quite unusual. Either they have at an early stage or maybe a old age people. So here that lady again was a cause of exposures, and when we analyzed for the mental analysis, she was also suffering from mercury. So what was the reason here? Cosmetics. She was using the fair looking cream, morning ka, afternoon ka, evening ka, night ka. चारों different creams उनके थे. That's a quite costly cream, 3,000-4,000 for that cost. And importantly that they, when we are also analyzing that cream that was containing very high mercury to make the people more brighter. They are adding the, an important thing is that mercury salts are very toxic. अगर किसी ने mercury thermometer में है, अगर किसी ने by chance गलती से भी किसी ने खा लिया, गलती से मुंह में चला गया, तो वो elemental mercury होता है, उतना वो toxicity नहीं करता. But if the mercury or any of the metals binds with the salts, these are very toxic, very toxic.
Any experience about Tulsi mercury induced problem? Tulsi has high content of mercury.
No, sir.
Tulsi leaves. That's the only oral source of mercury.
So that might be again in Tulsi, not known, but that may be an elemental mercury. So if it is there, elemental mercury, as I told you, sir, that may not be harmful. So many times even in water, we are having some of the, as we all know that in Bangladesh and West Bengal where they have got this drinking water.
High incidence of cheese mentioned carcinoma in Pujaris.
Pujaris में?
पूजा करने वाले
हाँ उसमें
कुर्सी खाते हैं,
अच्छा
मुंह में रहती है
हाँ यस यस
तो they were analyzing lung and kidney carcinoma.
oh
Dominant number of Pujaris.
okay so I have not gone through that but that might be the possibilities but as I told you sir that most of the time the elemental form of metals are not toxic okay but if it is bind with the salts that is quite toxic that ability to
So you regularly give protein with the understanding it's a bias thing to religious thing to do for health. You should play with it
okay
because it contains multiple. Right. Swallow is
swallow is okay but chewing may be releasing of some of the toxalbumin's point of view or something that will be okay okay so again that so again take home message educate we must have to do some of the mock drills in the industries because the industries are not that much ready for this kind of an activity so mock drills are very important even for the hospitals we have to do a mock drills for the mass disaster management for the chemical exposures if there is 100 people will come then how we will manage what are the decontaminations protocols what are the different kind of an antidotes that may be needed or many things so ultimately the preparedness is only the key to combat this kind of chemical disasters we have to do what we are doing here also that making awareness we have to ready with the equipment, resources, planning and exercise. We have to control the situation, otherwise situation will not control you. So hopefully that I am on time. Thank you so much. If any questions?
Can you give us guidelines? Suppose tomorrow we have 4 workers cleaning up main homes. Broad concept. What do we do?
Sir.
What will be our sequence of intervention?
So sequence of interventions that most commonly that what we found in the mangrove workers there are any kind of toxicity happens and the person is very critical due to the H2S exposures. So if you are just having a patient on admission, severe hypertension, metabolic acidosis and all the signs and symptoms are related to this kind of a criticality, then immediately we should give at least the symptomatic management only. Because this is a very specific one which may be because once that self-hemoglobin is going to be converted to the normal oxyhemoglobin. The nitrate have the capacity to remove the self compound from the hemoglobin.
Number 2, chlorine carried trucks accident, ammonia carried trucks accidents are not rare. So if we have a road traffic accident and some workers are brought or some, what do we do?
So उसमें तो we are having a proper protocol for the chlorine or the ammonia exposures as I told you the respiratory.
Can you give us a proper?
Definitely, sir. Definitely. Yeah, any other? So hopefully I am not afraid. I am making not afraid the females of utilizing the cosmetics. कंटेंट से मेरा कोई भी कुछ भी लिखा है हमने अभी अहमदाबाद में काफी लिपस्टिक्स के कंटेंट्स चेक किए थे बहुत ही ब्रांडेड लिपस्टिक्स दे आर ऑल कंटेनिंग लेड
Lipstick cannot be made without.
हाँ तो there might be the possibilities of having this
All friends be careful of
thank you so much
Thank you so much.
This topic which is generally not taken up. And I believe that this industrial part is still to be explored by hospitals in terms that whenever it will happen in your area and we might not be aware of what to do and what protocol and preparedness might be like. Right?
thank you
Another very important topic. Let's move ahead with alpha splicing. A very common thing, very no, varied management protocols taken up. So we have Dr. Naren Munta sir to give us the protocolized management for.
You know, aluminum phosphide or cellulose or many branded aluminum phosphide preparations are available. And there are two substances. One is organophosphorus and another is aluminum phosphide. These are the commonest poisons that we have been dealing with since we have been students of medicine. Right during post-graduation. And we have almost overcome the problem of COVID poisoning. The patient is brought alive, near alive, unless he is in the terminal phase with multi-organ failure. But aluminum phosphide still remains in challenge. And my presentation is based on guidelines of poisoning published in form of book by us in 2023 and a position statement that was published in 2024 subsequently. I have reviewed about 83 publications on aluminum phosphide and our own paper on aluminum phosphide, which is, I hope, gets published very soon. It is under review, and we have replied to several questions several times because it's a path-breaking publication probably. That's why the editors are quite not very keen to publish it too early before they have many answers from us. This is the book. You can have it from bookseller, publisher. We have been talking about incidents of poisonings in our country globally. However, whatever data we have, I am sure it is tip of iceberg. Because we do not have any data from rural area, we do not have any data from semi-urban areas. Because they are not reported, correct diagnosis is not made, the hospitals do not report them, and therefore they are ignored. Our own record shows of all cases, aluminum phosphide constitutes about 24%, organophosphorus about the same number, snake bites nearly the same, and the rest of are followed by corrosives and all others. Now that this data was compiled around 2022, now parapet is coming up very fast in northern India, maybe elsewhere also, but we don't deal with, as I said earlier, because we have found, after dealing with 3-4 cases, we found that it's quite frustrating, and ultimately we have to buy dust, and we do not feel happy when we are treating a case of poisoning, which we have never dealt with, we do not know anything about that, so we refer them to the best place they think. If they So, let me start with the case. A 20-year-old female brought to the emergency department with complaints of pain, abdomen, nausea, vomiting, restlessness after alleged consumption of a fresh tablet of grain fumigant 2 hours ago. On examination, extremities are cold, You cannot miss the typical garlic smell, you cannot stand even there. Others present in that room will also feel the punch of it. She is restless, but she is conscious, retching. This is typical. They are talking until the last breath. And they are feeling sorry that after मैंने बहुत गलत किया ऐसे नहीं करूँगी इस टाइम मुझे बचा लो. And the next second she is dead. Heart rate is very high, BP is very low, respiratory rate is very high, it is deep and acidotic. What is deep acidotic? You cannot miss the acidotic breathe. Patient is, abdomen becomes scaphoid, it swells up and it is very, very rapid. So this is typical acidotic breathing. SpO2 remains good for most of the time unless the patient BP falls and peripheral circulation almost becomes to naught. ABG is typical. It is typical. Unless you have ABG like this, patient really has not developed aluminum phosphide toxicity. pH is 7.2 or less. PCO2 has to be low because the patient is hyperventilating. Therefore, CO2 washout will take place. PO2 is good, I told you. Bicarbonates become low. Bicarbonates become very low despite good urine output. These patients do not have renal failure. Some of them may reduce during the preceding hours, and they may have some rise of urea, seldom have rise of creatinine, seldom have evidence of acute tubular necrosis. Seldom they have hyperkalemia or hypermagnesemia. So all these patients, have some degree of pre-renal failure because of hypertension. Why their bicarbonates go down? I'm going to discuss that a little bit. Their X-rays are normal. Most of these patients, I will say all of them are hypoglycemic. Why hypoglycemia? Because it is related to the factors related to the time period preceding their attempt to commit suicide. Patient has been in abnormal state of mind preceding he or she consumes aluminum phosphide salt, and during that period I am sure nobody would take food or any drink that would maintain her blood sugar higher or close to normal. On top of that, they have been relentlessly vomiting after consumption of the poison. And then there is hypotension, and there might be other factors. There are trials that hyperinsulinemia help these patients. So what might be over time secreting good levels of insulin? We have to do that research, find out their insulin levels while they are acutely toxic with aluminum phosphide. So there is a possibility of hyperinsulinemic state in these patients. All of them would show hypoglycemia, and that is one factor which is missed out totally by most of us. And if we let hypoglycemia sustain, our outcome will not be good in these patients. So always look for hypoglycemia, treat it, control it. Little bit of hyperglycemic patient is okay. I am okay with even 300 blood sugar, maybe for one day. That's okay. Heavens are not going to fall. X-ray chest is normal. They do not suffer from pulmonary edema unless somebody has given them a lot of fluid to treat resuscitate for hypotension, because they are not quite fluid tolerant. Ejection fraction goes down. It is cardiogenic shock. And if we do point of care ultrasound for them, you will find that on arrival the ejection fraction was somewhere around 50. After 6 hours it has gone down to 30. After 12 hours it has gone down to 25. And after 24 hours it goes down to around 15, 18. Patient is just surviving, heart is just surviving. Look at the contracting heart, beating heart, you will find that it is hardly contracting. It is dilating, it is a little bit of collapsing, it is dilating, it is a little bit of collapsing. Even an amateur doctor would understand that this is not the best heart I want to see. This is not a contracting heart. This is dilating heart. This is collapsing heart. This is not a beating heart. So, our observations, and that would be probably most of clinicians' observations. Our 28 cases, vomiting in awe, pain abdomen, consciousness was intact, all had metabolic acidosis of variable degree from pH of 6.8 to 7.2. I don't entertain a diagnosis of aluminum phosphide poisoning unless pH is below 7.25. If pH is above 7.25, you can earlier say before the poison has started acting, you may have a pH of 7.3, 7.32, but very fast it will fall below 7.2 or around. 6.8, 6.9, less than 7 is not rare finding. In a full-fledged case of aluminum phosphide poisoning, hypotension, everybody would have hypotension sooner or later, maybe 30 minutes, maybe 1 hour after arrival. I have calls from my residents at 2 a.m. Sir, there is a case of Telford poisoning, BP is okay, pH is okay, and he wants to do decontamination, gastric no needs. He still does it, and then he sleeps, and only to find that the patient is. Then he gives me a ring at 3 a.m. again. Sir, उसका तो BP नहीं आ रहा, KBG कराया था 6.9. कैसे हो गया sir? He was all right, fine, and transferred to ICU, and the ICU resident informed that the patient is. Evidence of AKI nil. Now the patient had loss of consciousness, low ejection fraction, tachyarrhythmias, hypokalemia, a little bit hypomagnesemia, few pulmonary edema, 6 patients who had been resuscitated with fluid, and so what is happening? Dr. Malala was talking about phosphine yesterday, Dr. Tejas was talking about phosphine. As soon as the active salt of aluminum phosphide comes in contact with air or aqueous solution, water or gastric juice, which contains large quantity of water, phosphine gas is released. So it is the phosphine gas which is very fast absorbed through the gastric membrane, gastric mucosa. It is emitted through oral cavity and it is absorbed through gastric mucosa into lungs and direct diffusion of the gas through the tissues into the lungs. So there are 3 mechanisms. One, its absorption and its dissemination into blood, its emission and its direct absorption into lung. Therefore, its pH content of the mother compound important role. And what is the pH phosphine compound of the content of the compound? It depends on age of the salt. When it was bought, it kept in the house or wherever it was kept, or how was the packet damaged. If it is exposed to air, definitely the patient will not suffer. So it is the phosphine compound, content of the compound ultimately. So it is production of phosphine in stomach. Once you understand the pathophysiology, and this pathophysiology is not speculative. To us, it looks good, it looks definitive. what is speculative is the way we are handling these cases and trying to manage them. So it is absorbed from gastric mucosa, enters the cell, and in the cells it acts at the mitochondria and blocks the entry of pyruvate into mitochondria. What is pyruvate? We are going to talk about it. This pyruvate accumulates, and this pyruvate, it's the end product of glucose metabolism. It has got two pathways. Either it enters the mitochondria, which is the usual in normal health, and it is ultimately converted into water and carbon dioxide through a mechanism of chain of events while producing some energy, ATPs. If it does not find entry into mitochondria, then alternatively body has to find another path of energy production. And another path of energy production is its conversion into lactate. So there are two possible mechanisms. So let me come here. Now, this is little important from the point of view. So this is the area below this line is mitochondria. Area above is pre-mitochondria area inside the cell. Here inside a cell, after glucose metabolism, glycogen is broken into glucose and it is ultimately producing pyruvate. This pyruvate must enter mitochondria to ultimately produce ATP, and final outcome is CO2 and water production. If by any hindrance or mechanism it does not find entry, one, or if finds entry, then the acetyl coenzyme A, which is found, it is inactivated. So we do not know what is happening there, but this pyruvate ultimately, if it is accumulated here, which actually happens in these patients, it is converted into lactate and some ATPs are produced. This is anaerobic. This also happens in all cases of sepsis, where there is anoxia, hypoxia, and there is not enough oxygen available. And this is also called anaerobic mechanism. When we do not have aerobic mechanism of energy production, we have alternate pathway of anaerobic energy production. So then, and this lactate formation is the ultimate mechanism of acidosis, right? So all these patients would have hyperlactatemia. To what extent? First ABG, you will find lactate 6, 7, 8. Ultimately, you will find that lactate more than 50. Most of the ABG machines would detect lactate. They will mention when you have high lactate, more than 50. Few ABG machines may also tell you lactate is 25, 26, like this. So this hyperlactatemia or high level of lactate would neutralize the bicarbonates produced by the kidneys. Because ultimate mechanism of acid-base balancing is, acid titrates with base. So there is high production of lactic acid, and this lactic acid is neutralized by bicarbonates. Kidneys have limited production of bicarbonates, normal bicarbonate production. So that is why when you have CO2 production, a patient who is retaining a lot of CO2, you will find that bicarbonates do not rise very rapidly. But if you have a patient of metabolic acidosis, you will find that respiratory center is stimulated immediately in minutes, and you have acidotic breathing. and therefore CO2 is washed out. CO3, this bicarbonate production, to be enhanced, to be stimulated, takes a little bit of time, maybe 10 hours, 12 hours. But here, kidney function is already compromised because there is hypotension. Renal perfusion is compromised. All these patients, none of these patients would have blood pressure of 100 plus. Most of them would be hypotensive to the level that blood pressure may be unrecordable. And it's a cardiogenic shock, worst kind of shock. So there is severe metabolic sustained acidosis. And this sustained acidosis further leads to myocardial depression. In one of the presentations you might have heard yesterday, metabolic acidosis is the worst kind of myocardial depressant. So there is acidosis induced myocardial depression, further depressing the myocardium, further cardiogenic inactivity, and there is possibility of direct myocarditis. There are other number of mechanisms which have been proposed in literature. I have typed them in microscopy because to my understanding they are quite speculative in nature. None of them are able to explain everything so minutely as this mechanism does. Therefore, I will proceed further towards sequence of events. So there is a massive and challenge lactic metabolic acidosis, acute myocardial depression, all cardiac functions are disturbed. Worst is contractility, to large extent heart rate, so you have tachycardia, and even rhythm is disturbed. Conduction, what we call as spasmotropic action of heart, is also disturbed. So rhythm is also disturbed. Conduction abnormalities are also observed on ECGs. So low ejection fraction as low as 15, from 55 within a matter of few hours. Tachyarrhythmias mainly, but we do see bradycardia in occasional patients. Normal sensorium is maintained in most patients or all patients. If there is a compromise of consciousness, always think the patient has taken some benzodiazepines or some neural depressing drugs for purpose of suicide or to control depression before consuming aluminum phosphide. So these patients, aluminum phosphide seldom would cause loss of consciousness. Nausea, vomiting and pain are not direct effect of poison. Hypoglycemia, I have already talked to you. So management in ER. So this explains the pathophysiology and why we see all those symptoms and signs in these patients. Confirm the diagnosis, which is extremely easy. If you understand, if you have ever observed a case of aluminum phosphide, you can't miss the smell and the typical clinical picture, the ABG. Such ABG you will not find in any other patient combined with echocardiographic finding. So confirmation of diagnosis, monitoring resuscitation, administration of antidote. This is what we practice. You've been hearing from speakers the approach to a patient of poisoning. Additional management is specific to the poison, supportive and symptomatic management, and if the patient does not reach some heroic measures if you want to take to save the patient's life. So our case, confirmation of diagnosis was done with all those clinical findings, observations and diagnostic tests, including smell, clinical picture, EVG, etc. And if all of the above are present, there are no tests needed. And there is no test exists to the best of my knowledge in literature which would confirm or exclude a possibility of aluminum phosphide. I don't think there is any confirmatory test. So the clinical evidence is strong enough. Resuscitation. This is what we practice, and this has helped us in saving many patients. And this is all about, because what I was talking about our paper, so there is a little bit of controversy in medicine research. If you have not been able to create a controversy, you have been an ineffective scholar. if you have to be an effective scholar or a presenter, then you must create controversies. And I heard the best speakers in the world ultimately telling if there are no questions, then I have failed because I have not been able to create any controversies whatsoever during my presentation. So this has already become quite controversial, and we are struggling to see that our paper is published with these interventions what we have did. Sodium carbonate, bicarbonate 8.4%, 2 liters in 90 minutes was infused to all these victims. 2 liters, say for a 50 kg patient, 20 ml per kg. No other crystalloid were used. That means we replaced normal saline resuscitation with sodium bicarbonate resuscitation. Target, what was the target? 2. pH 7.2, which was the principal target, and blood pressure systolic 90. It was not in our hands to achieve that kind of systolic BP, but we would not sit idle until we achieved a pH of 7.2. Most of the time we would do that, but if we would not get 7.2 pH, we would resort to some other, I'll come to that, other interventions. And we would always initiate 50% dextrose, 100 ml stat on arrival of the patient, even before we have results of, say, blood glucose levels, and or after that, and try to maintain a blood sugar of more than 150 milligram at all times. And we will request our nurses to monitor blood sugar every 30 minutes, every 1 hour in the first 5-6 hours. So additional sodium bicarbonate we would give 100 ml per hour as a continuous infusion. And the next intervention we would do is hemodialysis. I would replace RRT with hemodialysis because RRT is a generic, but we don't recommend CRRT, we don't recommend SLED in these cases because the problem with aluminum phosphide is a very, very rapid deterioration of metabolic mishaps. So if you don't intervene with a very rapidly acting intervention, nothing will be effective. Hemodialysis will be a challenge in a patient who is badly hypotensive. So we would initiate early vasopressors in name of noradrenaline, usually additional vasopressin, and as soon as the patient would touch a blood pressure of 90 systolic, we would initiate dovitamin also because it is contractility of the patient, it is cardiogenic shock, and we successfully initiated dovitamin in all of these patients. Oxygen was started 6 liters by cannula because we thought that it will help not to enhance oxygen level which were good, but it will bring cardiac workload a little bit. So one of the actions of exogenous oxygen administration is bringing down work of breathing or work of heart. For any shock, universal recommendation of crystalloid, this was replaced by sodium bicarbonate in our case. However, literature of LP does not report any improvement or survival with use of any routine crystalloids. I refer to you of 83 papers, those were published about aluminum phosphide from various countries. However, there is definite report of improvement of survival with sodium bicarbonate, massive infusions from BSU, from Dr. Jaiswal and his group. We use their reference to use this particular modality. Subsequent quantity and quality of fluid will depend on patient's response and condition of lungs. Quantity will depend on the condition of lungs. If we have some evidence of pulmonary edema, quality would depend on level of hypernatremia because 8.4% sodium bicarbonate it will carry a lot of sodium also. But since the patient is undergoing simultaneous parallel hemodialysis, I think hypernatremia never prevailed. We never were troubled by probable hypernatremia that we were speculating. Early vasopressor therapy, as I told you. So, effect of severe correction of metabolic acidosis, give full correction of sodium bicarbonate to all cases of aluminum phosphate, all such patients. When we achieved this, and we achieved a correction of pH to 7.2, all patients were saved. Patients died only if we could not achieve this correction. And why we could not achieve this correction? Patient collapsed during dialysis or patients developed pulmonary edema. But there were very few. There were not many. ECHH mostly would reverse very, very fast. I will show you some very interesting graphs, graphical display of our parameters. Correct would usually be not reduced. Endotracheal intubation, whenever we did, all these patients died, collapsed. And we thought, why this is happening? We would bring down work of breathing, we will support the heart. There is a bad heart, cardiogenic shock is there, ejection fraction is 60. The patient is, the heart is already under stress, and any positive pressure breathing will further increase intrathoracic pressure, and the patient cannot sustain in these particular acute conditions. So we avoided mechanical ventilation in many of these patients, and this was not even required clinically. Subsequently, when we sat on it and were discussing should we patient any of these patients on mechanical. No antidote is recommended for ALP in literature. Sodium bicarbonate solution seems to be the best antidote as of now until we have a newer, better antidote available, and we should continue to strive for that. I am not saying that we have found one. I am saying that this is probably the best one we have at present. Removal of GI, you have heard enough. It is not possible. We should not attempt. It does not happen. You cannot remove the gas. It is gas which is important. What you will remove from stomach will be aluminium hydroxide, which is non-event. You are only wasting time and effort on that. So don't do that. Emesis is contraindicated. Patient may end up in aspiration. Hemodialysis was started within 1 hour of arrival of all these patients. After we see a pH of 7.2 or low, not above higher pH levels. Settings were kept, no fluid removal, low flow, about 100, additional sodium bicarbonate added to the acidic fluid if it was allowed, duration 4 hours. If it could be achieved, maximum 4 cycles per day, 4 dialysis cycles per day. Some cycles had to be stopped after 30 minutes, some were stopped after 15 minutes, but started again as soon as the duty doctor probably thought, or the technician thought that we can do it again. Fortunately, I had a very good technician who was expert in handling these patients with dialysis machines. Each spell of SD would generate bicarbonates indigenously, which appear to be life-saving in these patients to us. Lactate is not dialysable molecule. It can be neutralized with bicarbonates. So discussion on HD strategies, RRT in any form we started earlier, generates bicarbonates. CRRT is a very slow process. What SD does in 4 hours, CRRT would do it 2 days, and in 3 days the total story of aluminum phosphide poisoning is over. By the end of the third day, when the patient comes, you come to know whether you are going to save the patient or the patient is going to die or might have died already. Most patients of severe ALP poisoning died within 24 hours of arrival. Most, those who have to die, they would die mostly within 72 hours. And after 72 hours pass, we feel pretty confident. Most of these patients, unless something very abnormal happens in these patients would collapse. Some few patients did collapse. We did SD in at least 12 patients, as many as 4 times a day, and short spells of 30 to 60 minutes. 4 hours spell is the best bet we think we can achieve. No dose of noradrenaline is too high. We think if we can maintain hemodialysis going on, because it's a short-term requirement. Ultimately, if the patient is saved, all is well. Our patient after 12 hours, conscious, irritable, BP 92, systolic, pulse, not very bad, respiratory rate again 22, acceptable, ABG about 7.2, blood sugar 158, LFT is normal, RFT is normal, electrolytes normal, magnesium normal, calcium chloride infusion was initiated, 5 ml, this is one basis of literature. When you correct metabolic acidosis with heavy doses of sodium bicarbonate and with hemodialysis, calcium helps in maintaining hemodynamics. X-ray chest was NAD, echo, evidence of dilated cardiomyopathy, ejection fraction improved to 34. So correction of metabolic acidosis with RRT and sodium bicarbonate boluses. And this is the graph I was talking of. You see, serially, we have 5 parameters: pH, bicarbonate, lactate, SBP, systolic blood pressure, and ejection fraction. So this relates to dialysis, hemodialysis. With dialysis in 12 hours, 6 hours, 12 hours, 24 hours, 48 hours. Look at the pH. This is pH. So this is pH. This is lactate. Lactates are going down. pH is going up because it is in points. pH is in points, 7.6, 6.8, 6.9. Ultimate our target is 7.2. So the curve's movement looks, the height increase is just negligible. You have to look very minutely to appreciate the height. When you look at the bicarbonate level, there is a steep rise. Look at the LBF, infection fraction. There is a steep rise. Look at the LBF. So this is the relationship we could chart out in all of our patients. So our patient after 36 hours conscious, all parameters, clinical parameters fine, ABG very fine, blood sugar good, echo, ejection fraction improved. Other findings are non-conspicuous. Our patient after 36 to 72 hours, there was a fall in BP after SD late. Secondly, it had to be suspended. Vasopressors were augmented. SD initiated as soon as BP was achieved, and subsequently the patient recovered. So currently, since we have a mortality of ECMO भी है, ECMO का कौन कर रहा presentation? एल्यूमिनियम फॉस्फाइड विवेक का तो कितना टाइम का है? So now you see currently lot of our colleagues are trying out ECMO in all aluminum phosphide patients and what they do and what is the philosophy. Philosophy is because we have discussed the ejection fraction goes down unacceptably low, very fast. So the philosophy is keep them alive on extracorporeal oxygenation for 72 hours, 3 days, 4 days. Most of them would need it for 2 days, 3 days until the effect of phosphine gas wears off. It's a good philosophy, but you see, you have to start very early. The socioeconomic group involved in these cases is of low middle income group, farming class, and to organize a finance of 2 lakh rupees a day and decide about in minutes rather than in hours is a challenge. And if you are starting ECMO late, then it's an automatic failed intervention. So that's the challenge. And there are 3 indications for ECMO. One is refractory arrhythmias, refractory cardiogenic shock, and cardiac arrest. So it's a refractory cardiogenic shock, no doubt about it. It's a case of refractory arrhythmias. If there are arrhythmias at all, most all patients would not have arrhythmias, but many patients would have arrhythmias. May present with BTEC itself, many of them. But can we salvage most of these patients or many of these patients with sodium bicarbonate being used as resuscitation fluid? I feel personally the cost-benefit ratio, acceptability ratios are very high. Very few challenges. The only challenge is hemodialysis, and it's not a small challenge. Again, availability of hemodialysis is not as frequent as we think in peripheries where the incidence of aluminum phosphide is very high. Therefore, where there is no SD, ECMO therefore would not be there by any speculation. So, I propose, and that's what we have recommended in our paper, sodium bicarbonate be accepted as both as antidote and resuscitation fluid in all cases of aluminum phosphide, and I have tried to explain why and how. Thank you very much. Magnesium has been used traditionally. Magnesium has been used in many situations in aluminum phosphide poisoning because there are arrhythmias. And it has been a good anti-arrhythmic drug in use for decades. Therefore, it was very popular. And whenever we would talk to our friends, "Kya kare yaar?" I am talking about 25 years back. Aluminum phosphide, sulfur poisoning ka case. Magnesium should go, magnesium should go. I remember very clearly. I heard the first talk on aluminum phosphide poisoning was by Dr. Wadia or somebody. Wadia, only Wadia, not Wadia. Only Dr. Wadia at Pune in 1998. Sulfur poisoning. And since then, very little progress has happened in salvaging these patients. Probably, if our study is published, our paper is published, will it be published? Most likely. So Prashant is part of authors and is pushing it hard, and we have answered several rounds of questions, remodeling the paper, because the editors rightly so finds it very controversial and may offend many researchers. So thank you very much.
Thank you so much, sir.
without a tea break, can we just grab a cup of tea and continue?
Yes.
Just grab a cup of tea. We'll wait for 5 minutes. Just grab your cup and we continue with that.
are also prone to ingest and overdose themselves. The incidence has been clearly 10,000 cases in 2012, has been rising with time. So, the clinical features are usually because of the drug action itself. The CCBs, whether they are dihydropiridine drugs or non-dihydropiridine, they are either working on the heart itself or the peripheral vasculature. So whatever effect they cause are because of the effect on the vasculature or because of the myocardium. Besides that, they can also act on the channels on the pancreas, which helps in secretion of insulin. So these features can be hemodynamic compromise, hypotension. If they are non-filtrating drugs, then they either verapamil or diltiazem. This can lead to bradycardia. Otherwise, dihydropiridine group of drugs they lead to tachycardia with hypotension. Then ECG changes. It also affects the SA node, so affecting the depolarization, leading to bradycardia as well as prolonged PR interval. The hyperglycemia I have already told you is a finding with the because it also affects the pancreatic calcium channels. So the severity depends on the dose being ingested. As high as more than 100 tablets have been reported to be ingested by patients, amounting to more than 12 grams of drugs being ingested. So the point is that how much the dose has been ingested could be due to the severity of the station. So diagnosis is again, history is very important, but the clinical scenario of hyperglycemia with hypotension and bradycardia supports CCP toxicity. The various definitions to be kept in mind is the beta blockers, the clonidine or toxicity. Cholinergic groups of drugs may have thrombocytopenia along with that, but they can mimic certainly CCP toxicity. And certain structural heart diseases may also present with hypotension and bradycardia. So treatment is how much the dose have been adjusted. So mild cases, those who have just maybe have had one step of may present hypotension and bradycardia. So initial management in those patients may be just IV fluids and atropine to counter the effect of the overdose. But very high doses, as high as 40 tablets, may lead to severe hypertension, may not respond to IV fluids and atropine. So there, the management will have to be stepped further. So initial stabilization always includes A, B, C, taking care of the airway, breathing, circulation. These patients, because of severe hypertension, may lose their consciousness or they may develop secondary problems because of breathing because of severe hypertension. So initial resuscitation with IV fluids specified will help. And then if there is severe bradycardia and the patient is unstable, IV injection atropine 0.6 mg, which can be repeated to maximum dose of 3 mg, can be done. So since most of these tablets are sustained-release tablets, so there is role of gastric decontamination activated charcoal or even coal irrigation, because these sustained-release tablets they keep on getting absorbed and will cause a long-lasting effect. So gastric decontamination has a role, especially if it is done within 2 hours. IV calcium to counteract the effect which has been produced because of the calcium channel blocker in the form of calcium chloride or calcium gluconate. Calcium gluconate, which we commonly use 30 to 60 ml, can be administered slowly, initially 30 to 60 ml, followed by infusion of 0.5 mg per kg per hour. IV glucagon bypasses the blocked calcium channels by activating the adenylate cyclase by GBP coupled receptors, increasing the intracellular availability of NAM and thereby augmenting chronotropy as well as antropy of the suppressed heart. So it can be given to counter severe type of myocardial suppression by the overdose of the calcium channel blockers. A bolus therapy of 1 to 5 mg IV. If it doesn't respond, you can continue with the infusion later on. Nausea and vomiting you have to counter because excess dose of glucagon will obviously can have these side effects. high dose of insulin with dextrose therapy has been used to counter the effects of excessive dose of CCDs. Insulin as high as 1 unit per kg body weight is given as IV bolus followed by 0.5 units per kg per hour as infusion. You will have to monitor sugars because hypoglycemia has to be prevented anyway by administering simultaneously dextrose. This IV insulin is known to augment the intramyocardial glucose metabolism and thereby increasing the anotropic effect or to counter the myocardial suppression. Beside these therapies, the other therapies which are also advisable as per to maintain the patient's parameters is very important is vasopressors, which are norepinephrine is the drug of choice. Besides this, to prevent the effective hypertension, because we can use between 1 to 2 milligram per kg body weight over 10 to 20 minutes. Besides this, another therapy which is recommended is IV lipid emulsion. So if it is severe, you will have to use all of these therapies recommended till now one by one in step-by-step fashion, starting with IV steroids, followed by atropine, then calcium, insulin, dextrose, then IV glucagon, vasopressors, and lipid emulsion if required, maybe in one go. So this is a step-by-step approach. Vasopressors, if you don't get any response from the initial treatments, should be used to maintain the hemodynamics. So since we are using insulin, calcium, so monitoring is an integral part of management of CCD toxicity. Serum calcium, serum potassium have to be closely monitored because you have to continue calcium supplementation along with insulin therapy. Blood glucose may be required to be monitored every 30 minutes to 1 hour as required. Simultaneously, the patients may start behaving, having a normal BP and maintaining their hemodynamics. But for the part of arrhythmias, they need to be monitored at least 48 hours even after injection of the CCDs. So, you have to recognize early these patients based on their therapy along with the triad of hypotension, bradycardia, and hyperglycemia. Decontaminate promptly, escalate without hesitation to the step-by-step therapy, and hide or the insulin dextrose is a priority agent. Those which don't respond may require ECMO and other adjuvant therapies to prevent or maintain hemodynamics till the effect of the CCDs wither off. Thank you. Thank you.
Thank you, Dr. Puneet, for this. Another important toxicity which we would like to cover before we move on to the case management is opioid. And let's hear it from Dr. Shruti Sharma, Associate Professor, Critical Care Medicine from DMC Ludhiana, and she is also a very active part of our overview.
Good afternoon, everybody. I thank the professor for giving me this opportunity as well as thank the organizers and also thank the Swami Vivekananda Mission Society and Charitable Hospital for hosting this wonderful event, and you all have been a tremendous audience sitting patiently and listening to all the thanks to Dr. Kunjan also. And this is another topic, and in our part of the, you can say, India, we face a lot of patients with opioid crisis. And this becomes more complicated because they are already opioid dependent, taking various types of drugs, opiates, heroin, So when they come in toxicity, they present differently and they have other background issues also. So I will be touching very briefly on those issues because we are slightly short of time. So first of all, what is the problem statement? In India, India has twice the global prevalence of the opioid use all over the world. So India has twice the global prevalence and more than prevalence, half the prevalence of opioid use in India is by UP, Punjab, Haryana, Maharashtra, MP, Delhi and Andhra Pradesh. So this may be because opium is impregnated into our social customs. Our older dadi, nannies and before that they used to take opium as a regular user. But recently what has happened is because of the advancement in the semi-synthetic and synthetic compounds such as fentanyl, heroin and tramadol, things like these are available now illegally. And now our country and especially our part of Punjab, Haryana, it has become a quite epidemic proportions has occurred. So we must understand the problem statement and the overdose deaths can be explained in three waves. Initial wave started in 1990s when the opioid deaths were due to the overuse of the prescription drugs or opium consumption. But second wave in 2010 started when the heroin use became prevalent. So youth will take a lot of heroin injections inadvertent and they will land up in the emergency. And the third due to mostly the overdose of synthetic opioids such as tramadol, heroin, fentanyl. So we have passed through three phases of the epidemics in concern of the death due to opioid use. So these are the type of opioids available. Some are natural compounds, some are semi-synthetic and some are synthetic. So these are all available illegally or legally and our youth becomes habitual to it. So this is in little bit of detail. This depends on potency also. The fentanyl is the highest potent agent and now commonly used as an abuse drug, whereas codeine has the lowest potential. So that also results in different type of opioid dependence if you consume these substances. So mechanism of action, we know that they act on the mu receptors and the mu receptors is responsible for if morphine and sulfentanyl are the selective agonist and antagonists are naloxone and nalbuphine. And this leads to respiratory depression, meiosis, euphoria and muscular rigidity, sedation and physical dependence. Morphine and its congeners also act on kappa receptors, delta receptors, but that is not responsible for the physical dependence. So physical dependence occurs due to its action on the mu receptors. And morphine and fentanyl are the agonists at these receptors. Partial agonists are buprenorphine, and buprenorphine is used in de-addiction also because it causes lesser physical dependence. So in de-addiction centers they are using buprenorphine with naloxone for this and it has a lower abuse potential. Then comes the mixed antagonist agonists and then another antagonist that is naloxone and naltrexone. So these are the issues that are come along with opioid use, physical dependence and psychological dependence. Opioid dependence or tolerance occurs when there is need of higher or more frequent dosing to achieve the desired same effect. So people who are habitual try to obtain the same euphoria, same effect and keep on taking these again and again, and when they take inadvertent high dose, they end up in opioid toxicity and land up in the emergency. And opium withdrawal is another issue, which is because of the over excitation and sympathetic overactivity. And these patients can also come in the emergency when the desired dose is not available, and then they land up in the withdrawal syndrome. So to diagnose these patients, different type of patients can come with opioid toxicity. To diagnose, we follow the toxicomic approach. These patients will have analgesia, euphoria, meiosis, pink point pupils will be there, constipation, they will be sedated, and itching and red eyes can be due to histamine release, and respiratory depression, decreased cough reflex, and decreased level of consciousness, hypotension, and bradycardia. So dealing with this patient goes on the same line, that is A, B, C, aerial breathing circulation. Then naloxone, as we all know, it is an antidote and a drug of choice. 400 micrograms of naloxone initially as a test dose, then further doses are given till the desired effect is achieved. And history taking of the person is also very important because which drug has been taken, if it is heroin, if it has been opioid, cocaine, whatever has been taken, fentanyl, because their onset of action, peak effect, and withdrawal symptoms, this will vary. So how many injections has been taken, this or history taking is also very important, or any other agent was taken along with it. This has to be taken care of. So ABC, naloxone, these are the drug of management of choice, and co-injection should be asked for. So naloxone onset of action is 1 to 2 minutes, and the peak effect occurs in 5 to 15 minutes. So long-standing drugs which have a longer duration of action and peak effect, whether they have been consumed by the patient, so we may have to repeat naloxone again and again, and or continuous infusion can be used. So morphine or oxycodone may need a dose of 0.4 to 2 mg, whereas high potency opioids such as fentanyl may need a higher dose because they are highly potent compounds. For example, I would want to state this case. There was a young boy who presented with cellulitis in arms and he came with the opioid withdrawal syndrome. There was history of intake of heroin. Inhalational heroin he was taking from 2-3 years. 2-3 years he was dependent on heroin and inhalational. Now he was on injectable heroin addiction and he was taking tramadol as well as cough syrup. So he was taking pretty much everything. So that patient landed in emergency in opioid withdrawal syndrome. So how do we manage this patient? So another case scenario which is very common in ICUs, there was a female. You can say that females may not present with opioid toxicity or dependence, but here we missed this because this was a 50 years female who was operated for intestinal obstruction. She came after post-operatively. She was initially on fentanyl and fentanyl was weaned off. So whenever we were trying to wean the patient from ventilation, so she was not being weaned off. 2-3 attempts were taken and she will become restless and hyperactivity was there and we again had to start fentanyl. So then when we took a history from the relatives, they told me she has been taking opioid, she is a opioid user, she has been taking opioid. So we had to gradually reduce, again restart the fentanyl infusion and gradually reduce the dose of fentanyl infusion and put her on methadone or some other drug which is a long-acting drug to handle her opioid dependence. So these situations may come across when you are handling the patient in emergency or handling the patient in ICUs. So this I can skip off. So what are the signs and symptoms of opioid withdrawal syndrome? So this is a different than the opioid toxicity. Withdrawal syndrome will present with autonomic hyperactivity. There could be tachycardia, hypotension, hypothermia, diaphoresis, and midriasis will be there. There it was pinpoint people, here it will be midriasis, as well as other respiratory, neuromuscular, and respiratory, gastrointestinal, increased nervous output, diarrhea. This type of symptoms will be there. So basically, the idea is that we have to be careful what kind of patients we are receiving. The patient has presented with opioid toxicity or it is a withdrawal syndrome. And what is the previous history? Was the patient opioid tolerant or dependent? And after acute management and for substitution therapy, we shift them on opioid substitution therapy so that withdrawal effects is not there. Withdrawal syndrome, they don't land up in the withdrawal syndrome. So how to prevent and manage opioid withdrawal syndrome? There should be gradual opioid dose reduction. Substitute short-acting opioid with the long-acting such as methadone, buprenorphine and clonidine. तो जब ये पेशेंट को हम डिस्चार्ज करते हैं या वार्ड में शिफ्ट करते हैं, we ask the psychiatric people and they put them on buprenorphine or buprenorphine naloxone combinations. And multimodal, we can try other analgesics rather than fentanyl. Multimodal analgesia, alpha-2 agonist can be used such as dexmedetomidine, and clonidine can be used to handle the symptoms of the withdrawal syndrome. Tramadol can be used for the time patient is in ICU or in admitted setup, but it shouldn't be used at the home substitution therapy. And we have to prevent delirium in this patient. Opioid toxicity, opioid withdrawal syndrome, both can have delirium. So haloperidol is the drug of choice. Benzodiazepine can be used, but they may precipitate delirium in these patients. So preferably haloperidol can be used. And transitioning care and long-term planning should be done in these patients. Opioid toxicity managed in emergency, patient goes to ward or ICU. Then when you are shifting for long-term planning, there should be harm reduction counseling, there should be opioid substitution therapy and other family counseling, etc. should be done. So these two patients, the patient was initially managed with the first patient who was a heroin addict and tramadol addict. He was managed with dexmedetomidine infusion, which is an alpha-2 agonist fentanyl boluses were also given and haloperidol was given, and psychiatry call was sent, and the psychiatry people asked us to continue the dexmedetomidine, and patient was then shifted to buprenorphine and naloxone combination for a gradual de-addiction. And in case 2, which was a post-operative ventilated patient, symptoms were not related with that dexmed, so we had to start fentanyl again, gradually decreasing the dose of the fentanyl, and ultimately tramadol was started and psychiatric referral was taken. So, very summary points are, the opioid epidemic is a real threat to nation's health. Patient can present with opioid toxicity or opioid withdrawal syndrome scenario, both can happen. So, keep a high index of suspicion while history taking and anticipate the opioid withdrawal syndrome also whenever possible. Recognize the symptoms and alpha-2 agonist and dexmedetomidine and clonidine are the wonderful drugs, should be used in management as well as tramadol can be used, and gradual tapering of opioids, fentanyl, morphine in a hospital or ICU scenario should be done in the post-operative period using the opioid space strategy. This can prevent the iatrogenic withdrawal syndrome. So with that, thank you very much.
What is the best intervention to prevent withdrawal or minimize withdrawal symptoms?
Sir, if the patient is opioid dependent, we have to know the background history a little bit. Then we can, if we are already using opioids such as fentanyl with post-operative period, then we have to gradually reduce the fentanyl, and then we can shift them over to tramadol, which is a partial agonist tramadol. And if later, when we have to send them home or in a ward, then they can be shifted on a. If patient has an acute, has a short-term history. Tramadol, sir, if there is Raichu, then we can give by Raichu. IV injections are also available.
We can maintain the
Yes. And later they are shifted to buprenorphine. So sometimes the patient become de-addiction with the tramadol only. They can, put off the habit. But sometimes they are chronically dependent. Then they have to be shifted home with the buprenorphine or naloxone combination. With the psychiatric people, they give the counseling for that. Thank you, sir. Thank you.
Buprenorphine allows the combination with tramadol.
Buprenorphine is an agonist. At our, this is called opioid substitution therapy, OST. So all over India we have OST centers. So where these drugs are available. But the problem occurs, the patient, the youth becomes dependent also on these drugs. These drugs की history के साथ आते हैं कि फिर हमें कोई opioid नहीं मिलेगा. So problem is not settled there. But yes, these are available. So they give them एक हफ्ते बाद उनको आने को बोलते हैं कि आप अपना डोज लीजिएगा and the OST substitution therapy is given at this OST center.
Yes, smack will be very.
Okay.
So, we'll go for the cases, Dr. Anuj and the faculty certificates.
सभी को राम राम। For this certification, I would like to ask Dr. Anush sir, Dr. Tara ma'am, Dr. Narendra Gupta sir to give certificates. Our respected faculty, Dr. Gunjan Kaur ma'am. Dr. Shruti Sharma ma'am. Dr. Guneet Singh sir. And Dr. Prashant Kumar sir. Please come. Thank you so much everyone.
After this certificate distribution, we move to the SIM case management and कल जो मैंने रिक्वेस्ट किया था उससे आगे आज तो कल जितना झिझक भी नहीं रखना है, अपने छोटे छोटे ग्रुप्स की टीम लेके वी हैव टू वर्क फॉर द पेशेंट मैनेजमेंट, जैसे कि हमने इमरजेंसी या आईसीयू में पेशेंट को करना है, राइट? सो प्लीज डू पार्टिसिपेट, कोई भी झिझक नहीं रखनी है। दिस इज द बेस्ट प्लेस टू मेक मिस्टेक्स। आप कितनी भी मिस्टेक करिए, ना वो मैनेकिन हमको कुछ कहेगा और ना हम आपको कुछ कहेंगे, राइट? लेकिन जो भी हमारे मन में आता है उस चीज को हमें अप्लाई करना है, जिससे कि हमारे को अपना एक कॉन्सेप्ट, जो तरीका अडॉप्ट करने की हम बात करते हैं, वो हमारे मन में बस जाए, राइट? सो प्लीज बिल्कुल बिना झिझक के let us work on the SIM. Take this opportunity to revise, review, repeat, so that our mistakes are not repeated. So I'll request Dr. Tara, Dr. Anuj and Dr. Gupta sir to please distribute the certificates to all the participants. So I'll announce the names and I'll request you to come in front. Dr. Akshay Ambekar, Dr. Shubham Senwal, Dr. Harshit Goyal, Dr. Sunil Kumar, Dr. Ketan Divakar, Dr. Mohit Pratap Bharti, Dr. Vimlesh Yadav, Dr. Ashutosh Mishra, Dr. Vibhu Pratap Singh. Dr. Jiten Kumar Singh. Dr. Ashutosh Singh. Dr. Ratnesh Gupta. Dr. Pramod Ji. Dr. Pramod Ji, back, please. संघ के लिए स्पेशल राउंड ऑफ मिस काजल रानी, मिस सरिता देवी, निधि सिंह, डॉक्टर विजय पी रावत, डॉक्टर मृदुल शर्मा, डॉक्टर सपना भारद्वाज, डॉक्टर पानपुरी गुप्ता, डॉक्टर आकाश चौधरी, डॉक्टर कृष्ण कुमार जाधव, डॉक्टर कौशल पाराशर, डॉक्टर विशाल लोधी, डॉक्टर पंकज कुमार,
डॉक्टर संदीप तिवारी, डॉक्टर दीप्ति मेहता, मिस्टर तनुजा राणा, मिस्टर विनय, डॉक्टर राजेश विश्वास, डॉक्टर नंद किशोर सर, डॉक्टर मनीषा शर्मा,
बच्चे इनको नहीं मिला।
एक नाम से जाए।
आइए सर आइए।
बाद में मिलेगा ना, भाग गया तो फिर सबका क्या होगा? So let's move to the same, and I'm gonna keep that. Sorry.
I will request Dr. Anushika, CEO of this hospital and the Secretary of Swami Vivekananda Education Society, to give his concluding remarks.
कल भी मैंने कहा था कि बहुत ही एक अलग तरह का पिछले 2 साल से हमारे यहाँ एक्टिविटीज है, ऐसी वर्कशॉप्स और बहुत हाई क्वालिटी की, जिसमें पूरे देश से इतनी सीनियर फैकल्टीज आ रही हैं। तो स्पेशली हमारे हॉस्पिटल के डॉक्टर्स और स्टाफ को तो बहुत फायदा मिल रहा है इसका। थोड़ा डिस्टेंस का इशू है, देहरादून से थोड़े अभी भी पार्टिसिपेशन कम है, बट मेरे ख्याल से जैसे जैसे ये जाएगा कि ऐसी इतनी क्वालिटी वर्कशॉप्स हो रही हैं, तो फ्यूचर में थोड़ा अटेंडेंस बढ़ेगी। अब अप्रोच भी अच्छी हुई है, तो मैं सभी का बहुत बहुत धन्यवाद देना चाहता हूँ। और फ्यूचर में ऐसी हमारी और वर्कशॉप होती रहेंगी, क्योंकि सर हमें मोटिवेट करते रहते हैं, पुश करते रहते हैं, खाली मोटिवेशन नहीं। तो उसकी वजह से यहाँ पर ऐसी और साइंटिफिक कॉन्फ्रेंसेस होती रहेंगी। मैं सबका धन्यवाद देना चाहूँगा, स्पेशली इस हॉस्पिटल के एग्जीक्यूटिव डायरेक्टर और डॉक्टर तारा, डॉक्टर वैभव और जितनी भी हमारी इसके पीछे टीम लगी हुई है, पंकज शर्मा है, रंजीत हैं, बाकी जितना भी हमारा पर्दे के पीछे स्टाफ है, आईटी टीम है और जिन्होंने भोजन का सारा इंतजाम करा है, मेरे ख्याल से सबको पसंद आया होगा। इन हाउस ही सारा हमारा इंतजाम है और गैस क्राइसिस में भी तो सारा आपको शायद चूल्हे की रोटी हमने बनाई है, चूल्हे पे ही चावल चढ़ रहा है अभी लकड़ी का, तो वो अच्छा स्वाद आया होगा। और इतनी दूर से सारी फैकल्टीज आई हैं, तो सबका एक बार पुनः धन्यवाद और थैंक यू।
कोई खाने के पहले नहीं जाए यहाँ से, तुम लोगों को जरूर जाना होगा, लेकिन खाने के बाद जाए।
खाना हमने 4 बजे रखा है।
Good idea.
वो मजाक से खाना तो रेडी है।
Right, so let us work on the cases.
Yes, please.
4 जन और लो अपने साथ टीम में, 2 लेफ्ट से 2 राइट से।
कोई भी ऐसा कर लीजिए अपना अपना, इसके बाद कोई आपके मन में कोई भी क्वेश्चन हो तो वी विल लाइक टू एड्रेस दैट क्विकली। तो हम थोड़ा खाने के बाद वापस नहीं आना चाहते हैं, तो वी कैन डिले आवर लंच a little bit and before that we can address all queries that you might have.
All right. So अब थोड़ा सा गैप छोड़ेंगे वर्किंग टीम में और आप टीम में लगी हो। सो इमरजेंसी का पहला मरीज, राइट?
So 22 years old. हाँ जी, आ जाओ।
22 years old guy, bought by his mother, found in his room, sleeping, उठा नहीं पा रहे, बहुत देर से जो लग रहा है लेटा हुआ है, सांस ले रहा है, और इसके बेड साइड we have found strips of tablets. She's herself illiterate, so she can't read it. She has bought it along with it.
स्ट्रिप मंगाई है अभी, कोई और लेके आया
वो
है।
भूल गई हैं।
अरे सर कैसे करते हैं मुझे
यही तो
हाँ, very good.
हेलो, क्या हाल है?
ठीक हो?
ठीक हो?
Not responding. He just vital diagnosis. क्या टच कर रहे हैं?
ECG इलेक्ट्रोड बीपी पर
ECG कैरेटेड पैल्पेबल है। RBS 110.
सब रेडी
सर थोड़ा सा और
He's a party goer young boy. He's a party goer young boy. ठीक है। तो घर पे लेटा हुआ मदर को मिला है। And he was found to have
कैनुलेशन करो प्लीज, सैंपल दो, एबीजी इंक्लूडिंग एबीजी और ऑक्सीजन सैंपल,
ऑक्सीजन मास्क लगा दीजिए।
पीपल चेक करो,
Pupils are small in size.
एबीजी करिए, एबीजी करो।
सर एट्रोपिन दे दे, हार्ट रेट डाउन हो रही
Maybe 100
0.6
सर डन
एबीजी कर लेते हैं, एबीजी
ये भी सेंड ये भी जाने में टाइम है। सैंपल भेज
मैंने प्रोसेस को टाइम तो देना पड़ेगा, प्रोसेस के टाइम को
ऑक्सीजन अप्लाई,
ऑक्सीजन अटैच
ऑक्सीजन इज अटैच्ड।
एक फुट रेस्ट कर दो, बोलस naloxone is available, call for naloxone because it seems severe.
यस क्या बोल रहे हैं?
रेस्पिरेटरी कम है सर
ऑक्सीजन अप्लाई करिए, 30 डिग्री हेड अप, 30 डिग्री हेड अप, बेड को हेड अप कर दीजिए और ऑक्सीजन अप्लाई करिए और इसके बाद जो नैलोक्सोन
सर अभी भी रेडी नहीं है
रिपीट करो।
एक तो मैं पिक कर देता हूँ। नैलोक्सोन की गई है।
Then we can see what ABG says. If require, if she is totally unconscious, we should intubate.
GCS is E2 आवाज जैसे आपने दिया था भी he had started producing some sounds. B3 maybe M is flexing.
So probably we should intubate. Either intubate or we can give some supraglottic devices as well.
He has GCS of E2, B3, M5.
Then we then just we require oxygenation and then heart, oxygenation of heart, and then give fluid. Focus on fluid. At least 500 ml normal saline should be given.
So his GCS to begin with was probably initially not making sounds. You gave him atropine, the heart rate response. You gave him naloxone. His GCS made an effort of being B3 and M5. His RR was 7. Now it's 12.
सर एट्रोपिन
If a young boy, CCD and other poisonings are not that, that is less likely possibility.
Okay.
Most probably it is opioid.
So what else you want to do?
We have to generally just stabilize the patient, stabilization and naloxone.
So you gave more?
Fluid we can give.
You want to
if-
give more?
Yes sir, we can repeat naloxone.
We can repeat.
Double dose.
How frequent can be repeated?
I think 5-10 minutes, after 5 minutes we can repeat
Chalo.
it. And,
You can ask it to you.
give naloxone. Repeat the dose of naloxone. If it has been 40, then we can use 80.
400.
400. 800.
So आपने नलोक्सोन दिया है. He started waking up. His RR is better. His heart rate is coming up. He is waking up now.
बढ़ने शुरू हो गए सर हार्ट रेट.
अब मदर क्या कहना चाहोगे?
माता जी से पूछेंगे अब आप बेटर हो टाइम से.
दवा की
दवा की स्ट्रिप नहीं आई है सर. कैसा है मेरा बच्चा?
अभी तो पहले से तो जो हार्ट रेट है और पहले रिस्पॉन्ड नहीं कर रहे थे.
कुछ बोल रहा है.
नहीं, वो पूरी तरह होश में नहीं है. कोशिश कर रहे हैं इनको अभी स्टेबलाइज करने की कोशिश कर रहे हैं. आप हमें थोड़ा टाइम दीजिए. हाँ, थोड़ी देर बाद और उनकी स्थिति में सुधार आता है तो आपको बताते हैं.
ठीक हो रहा है ये अभी. उठ रहा है ना?
नहीं, अभी थोड़ा टाइम लगेगा. अभी आप मुझे आपको
पहले
बताने
नहीं
में
उठ रहा
time
था ना. उठ रहा है ना?
अभी थोड़ी
उठ
सी
जाएगा.
कोशिश कर रहे हैं. अभी हम देखते हैं, दवाइयाँ दे रहे हैं. मीनवाइल आपको वो दवा जो इन्होंने खाई थी उसकी पर्ची मंगवा दीजिए.
हाँ, मैं वो मंगवा ली मैंने.
सर इन द मीन टाइम हम लोग अपने हॉस्पिटल में इस पेशेंट का एक साइकेट्री वालों को बुला लेंगे. साइकेट्री और जो भी क्रिटिकल केयर में जहाँ भेजना है वहाँ पे हम साइन अप करेंगे.
आप बोल रहे थे CCD अनलाइकली. उसके लिए आप कुछ करना चाहते हैं? आप नोट कर लो. आपने he's responding.
कोई मेडिसिन ले रहे थे पास किसी कोई डिप्रेशन में थे या कोई उसमें कोई मेडिसिन ले रहे थे.
हार्ट की प्रॉब्लम.
हाँ सर, CCG 12 DCG निकाले थे उसमें.
सो आपने पिंपल्स चेक कर लिए. आपने ABG भेज दी. ABG भी आ गई है वापस. सो इट इज शोइंग PCO2 levels of 78. So and subsequently he has started responding to naloxone.
We can apply BiPAP.
So his GCS is around maybe 10.
Soda bicarb will not help in CO2 high. CO2 high, if there is CO2 high, then we have to give mechanical ventilation.
So meanwhile 1 hour passed by. She was getting the strips. We were awaiting the admission. We still find that his GCS is again dropping.
That's your medication.
Sir, we can either we can mechanical ventilation. If the GCS is above 7 or 8, then we can apply BiPAP, or if not, we should give mechanical ventilation.
वो जो ABG थी आपकी वो prior to naloxone administration थी. आपको बात की शायद अभी नहीं पता है ना? We are not aware of.
हाँ.
So we need not repeat it again.
So, but for BiPAP application, GCS should be good enough.
Yeah.
Otherwise, the patient will
dropping.
aspirate.
So आपने पहले almost for 1 hour you tried and prevented ventilation. Can you prevent it further?
Yes, we can prevent it.
How we can?
एक तो naloxone से रिपीट कर सकते हैं. दूसरा सर मैकेनिकल वेंटिलेशन बाय नॉन इन्वेजिव मेथड से हम.
If the GCS remains high, so we can administer naloxone by infusion or?
Yes.
So what would be the side effects looking for to prevent that? Side effects क्या हो सकते हैं naloxone से side effects? Sure.
मैं एक सवाल करूँगा.
Sir, please, sir, please. Sir, please, sir,
There is
please.
a query. What advantage you are going to have by applying ventilation or non-invasive ventilation? Either or. Non-invasive ventilation का तो सोचना ही नहीं चाहिए ऐसे पेशेंट में. Let me rule it out. Unless GCS is 15. not 10, not 8 or not 12. Why? Unless it is magically going to help. कौन सी है वो मैजिकली जिसके अंदर थोड़ा सा GCS कम भी हो और जिसमें NIV मैजिकली वुड हेल्प? CO2 रिटेंशन नहीं, नो नॉट CO2 नार्कोसिस में तो इंडिकेटेड ही नहीं है, कॉन्ट्राइंडिकेटेड
केसेस में हम लोग इवन इफ द GCS इज लोअर,
नो GCS इज ऑन लोअर साइड, वेर आई एम यूजिंग मैजिकली. It is going to do wonders in 30 minutes or 40 minutes or less than 1 hour. LVF, cardiogenic edema, LVF. It will show results within 1 hour or it will show results in 15 minutes. Patient will start telling, I am feeling better. और आप ये जो बार-बार
also if we in COPD cases also if
नो CO2 नार्कोसिस में तो मैकेनिकल ये आपका NIV इज रूल्ड आउट. नार्कोसिस आपने वर्ड यूज कर लिया तो इट इज रूल्ड आउट.
It has affected the brain.
राइट. नंबर 2, आप इसमें ऐसा क्या है कि जो वेट नहीं कर सकते? व्हाट हार्म इज गोइंग टू इनकर इफ यू waited for say 1 hour? Is the patient going to collapse? And I seek answers to these queries. Freely बात करिए, मैं तो वैसे ही है. आप ये बताइए कि इस पेशेंट में now that you know it is naloxone, opioid case, what harm is going to be there if you do not apply NIV or intubation?
sir, further CO2 narcosis will worsen.
That you can watch. मैं अभी की बात कर रहा हूँ. अभी आप NIV नहीं लगाओ और अभी आप वेट करते रहो 5-5 मिनट, 10-10 मिनट, 15-15 मिनट. आपका सेचुरेशन 94 आ रहा है, हार्ट रेट 64 आ गई, रेस्पिरेटरी रेट 15 आ गया. So what calamity is going to arrive if you don't apply NIV or don't intubate this patient? Review every 10 minutes से. आपके पास तो पड़ा हुआ लगा देना, कभी भी इंटीग्रेट कर देना.
ये है कुछ नहीं, मतलब you can
Yes,
keep on
तो कुछ आपको पेशेंट को कुछ हार्म हो सकता है क्या? पॉसिबली नहीं हो सकता, बिल्कुल भी नहीं हो सकता. बिकॉज ये तो ओपियम खा के आया है ना. 2-3 घंटे पीछे, 4 घंटे निकल चुके हैं. अब आपके पास है, आपके हाथ में सब कुछ इम्प्रूव हो रहा है. सो इंट्यूबेशन हैज इट्स ओन प्रॉब्लम्स. इंट्यूबेशन शुड ऑलवेज बी ए लास्ट रिसोर्ट. एनेस्थेटिस्ट हैं हम लोग, क्रिटिकल केयर वाले हैं, कर सकते हैं. दैट शुड नॉट ट्रिगर.
Sir, if
Pardon?
Examination, what are the reflexes? The intubation is an indication for airway protection. Is your patient maintaining reflexes? If patient is maintaining reflexes, that means my airway is not at risk in the ventilation. अगर airway risk पे है तो वो indication है before putting up a second intubation. ओके, पेशेंट ठीक है? यस मैडम, आपका भी डिस्कशन था, ठीक है? ऑलराइट, सो बिग राउंड ऑफ अप्लॉज फॉर ऑल. बट ओके, I'd like to review what happened to this patient. So, कौन-कौन था टीम में जो मैनेज कर रहे थे? आप, मैडम और सर, ओके.
सर एक क्वेरी है.
हाँ जी.
जैसे पेशेंट फुली स्टेबलाइज हो चुका है, आपने कहा कि क्रोनिक एनीमिया था, तो ही में है चांस ऑफ विड्रॉल सिम्टम, तो कैसे डिस्चार्ज करेंगे?
Discharge is obviously different for observation. Not we are not immediately discharge. He's as stabilized, then naloxone is again short. The discharge has to wither away, or he may again go into relapse after some time. Till you're certain whether he has ingested morphine, raw opium, tramadol, whatever he gets it in terms of history. So you have that will all help you deciding what kind of long-acting drug he has already ingested. So those things will help you. So you have to observe. तो यही बात सर बोल रहे ना 5 मिनट आपको हर 5 मिनट में एनालाइज करना है इनिशियल फेज इज वेरी इंपॉर्टेंट फॉर हिम सो दैट व्हाटएवर यू हैव डन यू हैव ट्राइड टू स्टेबलाइज द पेशेंट यू कैन स्टिल हैव अ रिडैप्ट
Okay. So what do you feel?
Sir, first of all, sir, we should, in this case, sir has rightly pointed out that it is a case of quiet poisoning because sir has told that he is a party guy, he used to take recreational drugs. Naloxone antidote availability is must for this type of cases.
So even if naloxone is not available,
Yes, sir.
we can manage this patient if we are keeping our eye on CO2
Yes, sir.
and we are not we do not let him die due to respiratory shock, the respiratory cessation, then we can supportive therapy can.
Anything better than CO2?
So pH.
Your
pH as
decision, pH.
Yes.
So pH is always important, is the only important. CO2 may be very high, but if he is a chronic taker
Yes.
and he has chronic CNS depression, chronic hypoventilation, then his bicarbonate levels will rise chronically. So we are happy with that.
Yes.
So if his pH is about 7.253, CO2 may be 75. So that should be our target. So always the thumb rule is always look at pH, not at CO2. This is in particular in relation to COPD patients. And same thing will apply here also.
Any modification you would like to do in management of such patient if he comes again?
Sir, we should try to act fast.
2 सेकंड में आईवी लग गया, 5 सेकंड में सब कुछ इन्वेस्टिगेट हो गया, और इससे फास्ट क्या कराओगे? इससे फास्ट तो फिर वो घर से ट्रीट होके ही आएगा. No, what modification you would like to work with if we get such a patient again after this workshop?
anything in the labs anything in the other cases
Sir, we will try to take reports little bit.
नहीं, इतनी इससे अर्ली नहीं चाहिए रिपोर्ट.
Sir, communication.
Okay, communication. Great. So what improvement in communication you think you need?
Sir, that we should decide the task done because I'm seeing being here I observe that there is a communication gap. So we are not able to coordinate that.
मैं तो एक बात बताऊँ, इस टीम में टीम लीडर कौन? Who was taking decisions? He was not taking.
Yes.
There was a team leader, but he was not taking a decision.
I was supposed to take the decision.
You were taking the
Yes,
decision. तो सर क्या कर रहे हैं?
We both are giving that right.
This is important.
Yes, sir.
This is important when we work in a team.
Yes, sir.
अगर किसी दूसरे की जरूरत है वो हमेशा लेगा. टीम लीडर डज नॉट मीन कि उसके अलावा कोई बोलेगा नहीं. ठीक है, लेकिन वो एक क्लियर मैसेज चाहिए कि अब कौन लीड कर रहा है और कौन किसको क्या कमांड दे रहा है जो कि वापस आ रहा है. Unless we have that, our team will not work. And probably that thing triggered to collapse of the team. Everyone was doing well, but there was no team ultimately left. सबने अपना अपना डिसीजन लिया, सबने अपना अपना ड्रग बोला और वो इम्प्लीमेंट किया, है ना. अब मदर से बात करने के लिए कौन बचा? So let us think about it. हम इसको प्रैक्टिस में ला सकते हैं. हम जब इतने सारे लोग हैं, तो why can't we divide our work? Right? Why can't we have a clear communication going, which is a loop communication? Right? Unless you close the loop, nothing will be done.
मुझे 2 सवाल और पूछूंगा क्लिनिकल एस्पेक्ट। यू डिसाइडेड वेरी अर्ली ऑन naloxone. Wonderful. Did anyone checked about naloxone है या नहीं है? I only heard guesses. अरे naloxone नहीं मिल रही तो एट्रोपिन दे दो। naloxone नहीं मिल रही किसने बताया? मैंने कहीं नहीं सुना किसी ने हमें ये कहा कि naloxone नहीं मिल रही। You never asked for naloxone. What happened? You suggested naloxone देना है। अब देना है, अच्छा लग रहा है सुनने में, naloxone देना है।
Very like few centers are there.
पर naloxone देना है तो उसका कोई प्रोसेस होगा। Either I need to ask him naloxone चेक करना स्टॉक में है या नहीं है, अगर आपको डाउट है तो, और अगर जवाब आता है कि नहीं है तब उसके बाद मेरा कोई एक्शन होगा कि naloxone नहीं है तो अब मुझे क्या करना है। क्या पता जवाब आ जाता है naloxone है, उसके बाद भी हमने naloxone दे दिया, ठीक है, सबने सुना naloxone दे दिया, कहाँ से आया, कितना दिया, IV दिया, IM दिया, मुंह में डाला, पैच लगाया, किसी को पता चला? इसका एक ही मतलब है naloxone गया नहीं। And that was the reason your patient didn't pick up the heart rate. आप सोचे बैठे हो, पहले आपने सोच के बैठे
Full command.
कि naloxone है नहीं, उसके बाद कहीं से naloxone दे दिया, किसने दिया, कितना दिया, कहाँ गया, भाई naloxone दे दिया, आपने मुझे दे दिया, आपने तो क्या दिया, दे दिया, वो तो मेरी जेब में है ना। Did my patient receive it? I just do not know. Patient will not respond till it is given to the patient.
It's like no response. I was saying that should we think something else? The challenge to naloxone did
One-
not respond.
one
We
experience
got-
of
दो ना,
opioid
दोगे
toxicity.
तभी तो बढ़ेगा।
One experience of opioid toxicity I would like to share. Once I ordered in ICU 40 mics of fentanyl infusion per hour. Post-op patient was there, patient was doing fine, and I went off duty. After 8 hours, when the duty was, staff was changing over, and the handing over, taking over was going on. Some staff called me, "Sir, the fentanyl is going at 8 ml per hour." When I wrote it, I told her 40 mics I wrote, and I told her 0.8 ml you have to give, and she started fentanyl at 8 ml per hour, and 400 mics per hour was going. I think 4-5-6 घंटे तक वैसे गया, and patient was literally gasping. Then the naloxone was used.
Not communication there.
Injection naloxone 400 microgram IV, give immediately and flush it with 20 ml of saline. Okay, so and it's not still a closed loop communication. She'll revert back. अब मैंने naloxone सुना हो, इन्होंने कुछ nalbuphine सुना हो, मैंने बोला हो और उन्होंने सुना, this is not closed loop. She'll revert back. I am going to give injection naloxone 400 microgram IV followed by a 20 ml flush. So she'll give it and then injection naloxone given. So this is a closed loop communication. So मैंने ये इसमें नहीं और भी चीज़ें होते ही है। आप अक्सर हमें आदत होती है एट्रोपेन को एट्रो बोलने की, ठीक है ना, नर्सिंग स्टाफ में ज़्यादा होती है और हम भी पिक कर लेते हैं। वो बोला जाता है इंजेक्शन एट्रोपेन या एट्रो, उधर से एट्राक्यूरम भी जाता है। This is how a team
एट्रा is used to be.
वो एट्रा वो एट्रो है, ठीक है ना, इतना ही है, वो एट्रा है वो एट्रो है ना। तो इसलिए क्लोज लूप कम्युनिकेशन में कंप्लीट नेम, डोज, रूट, any special precautions to be taken should be mentioned and should be reverted back.
Sir, my 2 to 3 queries in this case. One thing, how to confirm this is the opioid poison? Only the clinical basis, or you have some evidence in emergency? What test will arise from the emergency for the opioid poisoning?
So
It's very common.
Yes, sir.
No?
It's very common.
Because of the medical legal. Opioid mostly found in the European countries or in other countries, not in common in India.
I think it is toxicology basis. And
Yes, day 6 drug level, you can arise immediate from the emergency. and you found what is this? This is meiosis because of any insect bite or any something, any other thing. So first of all, you just raise the 6 drug panel immediately you rise. And the second question is how to discharge this patient. This is medical legal thing. तो ये अभी कई बार इन्होंने पहले भी पूछा था, बाद में भी पूछा था. और इन्फ्यूजन लगाने की नलोक्सोन की जरूरत क्या पड़ी? Why not intermittent dose, not efficient in this patient? Why you want to use the infusion?
Patient was not picking up.
Why?
क्योंकि उसे जा नहीं रहा था, समझो मेरी बात है प्लीज.
So second thing,
दिया होता तो
you people knows that distribution reaction. Always drug deposit in the adipose tissues. अगर पेशेंट हैवी है, 1 क्विंटल का है, 50 किलो का है, वो ड्रग कंजर्व करके रखता है अपने सारे वाइटल ऑर्गन्स में और वो डिफ्यूजली रिलीज करता रहता है धीरे धीरे. अभी आपने नैलोक्सोन दिया, थोड़ी देर में फिर म्यूज से वो रिस्पिरेटरी डिप्रेशन में चला गया या कार्डियक अरिथमिया आ गया या उसको एनी अदर जो भी 3-4 कॉम्प्लिकेशन होते हैं रिस्पिरेटरी पल्मोनरी वो भी है वो आ गए. So because preventing the redistribution of drug in a body, we are using to maintain the plasma concentration of naloxone. So this is the indication of any drug to achieve plasma concentration in a body. And last thing, जो सर ने बोला था, addition क्या करना है? Why not do before the discharge psychiatric reference, psychiatric evaluation? What is the prevention criteria? वो पेशेंट कल फिर खाएगा, फिर परसों खाएगा, फिर खाएगा, फिर आएगा, फिर खाएगा. So our scenario in ICU, we are discharging the patient at least 72 hours because of the all monitoring to be done and charted because of this case is medico legal. So we are discharging at least 72 hours. उससे पहले वो लामा जाता है. तो हमें करना चाहिए ताकि सारी ड्रग जितनी उसने कंज्यूम की है वो मैक्सिमम टाइम में सारे रिलीज हो जाए और जितने भी भारत कंट्री है उसमें तो ड्रग लेवल करा लेते हैं, फटाफट ड्रग लेवल करा लेते हैं. तो आई थिंक 2 to 3 थिंग्स, क्योंकि मियोसिस को डायग्नोस करना इट्स पॉइंट इज आई साइन इन आईसी. देयर इज बिग चैप्टर आई साइन इन आईसी. तो उसमें आप पीपल देख के आप फट से डीडीज बना लेते हैं और कंफर्मेशन किए बिना हम
pupil could be due to meiosis could be due to pontine hemorrhage as well.
because naloxone के ठीक ठाक कॉम्प्लिकेशन होते हैं. नॉयलॉक्सोन के ठीक ठाक कॉम्प्लिकेशन होते हैं, देखे गए हैं. अरिथमिया भी करता है, ट्रीमर, सीएनएस सिम्टम्स भी सारे देता है और म्यू की वजह से, म्यू रिसेप्टर की वजह से वो सारे रिस्पिरेटरी डिप्रेशन भी ठीक ठाक करता है अगर इनएडिक्वेट हमारा उसमें हुआ. तो 2-3 मुझे लगा कि ये क्वेश्चन इसमें होने चाहिए. एंड नेक्स्ट यू कैन डिस्कस दिस. और एनआईवी के लिए सर ने भी बोला था, तो मोस्टली ऐसे पेशेंट का अगर जीसीएस गिर रहा होता है, क्योंकि हमारी जो मॉनिटरिंग है, मिनिमम मॉनिटरिंग है 30 मिनट में हम मॉनिटर करते हैं. ऐसा नहीं है कि आदमी खड़ा रहता है जीसीएस के लिए. तो जो चार्टिंग हमारी होती है लीगली, तो उसमें अगर पेशेंट जो है वो एस्पिरेट करने के उसके बहुत चांसेस होते हैं. इसलिए आजकल के लोग प्रेफर नहीं करते हैं एनआईवी के लिए, खासतौर से.
अच्छा,
हाँ, किसी भी समय अगर है तो उसका अगर लैरिंजियल रिफ्लेक्स गया या उसके एयरवे रिफ्लेक्स गए, तो वो सबसे पहला जो हमने कॉम्प्लिकेशन जो हमने किया, उसके बाद फिर ना चाहते हुए भी पेशेंट को इंटुबेट करना पड़ता है. तो जब तक आपको लैरिंजियल अगर रिफ्लेक्स उसके मेंटेन है, तो मुझे लगता है कि आई थिंक. और सर एनी मोर थिंग रिगार्डिंग दिस? यस, जरूरी वो डिस्कस करना. Before starting the giving the drug and exactly.
And we should do the PI also.
Yes.
And patient give the consent, we can expect the other also.
Yes.
Also the poisoning cases are very unpredictable. So we should not give the false related.
Exactly. अगर नैलोक्सोन से कॉम्प्लिकेशन से वो मर गया तो फिर
not to be handed over to the patient party.
अगर आपने पीआई या एमएलसी में किया तो फिर तो हैंडओवर का तो सवाल समझ सकता. जब तक वहाँ से किसी और को टिकट दे दिया है कि अब इसका तुमने देखना है कि क्या हो. सर आपका कमेंट फॉर handling these situations in terms of medical? How hospitals should protect us?
Yeah, so it's a little different for government and private hospitals. So private hospitals, if the history is even of a suicide or something, it's not mandatory. But if death happens, they must report. But government hospitals, such cases like at least in South India, Karnataka and all, even if there's any doubt of suicidal intention, irrespective of whatever the prognosis, they will initiate a medical legal case. They will and inform the hospital outpost. Because for a government medical officer, it is mandatory. He has to report. If he hasn't reported and if something happens against the medical advice, if they go, it will come on the casualty medical officer. At a private hospital, yes, if it is attempt to suicide, they need not, it's not mandatory. But if death happens, there is no way that they can hand over without reporting.
I think in this case, narcotic drug is involved, so it should be informed.
Yeah, it will come NDPC and all that, especially if it is a opioid related poisoning. But the overdosage, Prashant sir, is whether it is accidental or somebody gave an overdose. That will always be.
Now, for specifically, if you look for the morphine, we talked about this morphine for this particular patient.
Yes.
It is on rise because of its availability, simply because of the pain physicians taking care of more and more patients, cancer patients, they are on routine morphine tablets. So its availability is on rise. So even in households, the availability is coming up because of some elderly or someone is on morphine tablets and it is available for other family members. We have seen couple of cases who came up because घर में जो बच्चा अपने किसी रिश्तेदार को लेके आता था उसको मालूम है कि हमको ये morphine मिलती है. And first thing we got someone कि वो कार्ड पे 3 दिन पहले morphine गई हुई थी और वो 3 दिन बाद दोबारा वो someone came into hospital ये दादी की और चाहिए दवाई खत्म हो गई. तो someone the pharmacist picked up the thing कि ये 3 दिन बाद दोबारा आ गया, ये मान नहीं रहा. Then थोड़ा सा ड्रिलिंग करने पे वो मालूम पड़ा कि वो आधी गोली तो उसके पास जा रही है. So things are much beyond what we can imagine. किसी को शक नहीं करना चाहते लेकिन हमें सोशल प्रोटेक्शन के लिए उस तरह से भी
टैबलेट में कुछ इसकी लवाज टैबलेट को लेकर आता है.
Now again, लवाज को मैं ये कहूँगा कि we should start thinking from a general perspective. अगर हमारा पेशेंट बिल्कुल इमीडिएट तो हम लवाज के लिए सोचें. लेकिन लवाज में टैबलेट कभी पकड़ नहीं आता. आप ऐसे भी सोचें निकालना क्या है टैबलेट तो अगर या तो वो भूल चुकी है तो आगे कर फिर हम पकड़ नहीं सकते. और अगर नहीं भूली होगी तो वो उस ट्यूब से वापस
हॉस्पिटल सेटिंग मोस्टली ट्रांसपोर्ट इज अवेलेबल दैट हैव नैरो
उससे कुछ नहीं बात है. एक सवाल रह जाता है कि राइस ट्यूब से आप सैंपल लेना चाहते हैं मेडिकल लीगल फॉरेंसिक के लिए, बट क्या उसका कुछ औचित्य बचता है प्रैक्टिकली? उसमें कुछ आएगा नहीं. दूसरा वो जब हम सील करके भेजते हैं वो जब असेस होता है तब तक वो
3 to 6 months
उसमें कुछ बचता नहीं.
Nothing not detected या आता है
उसमें because there is a huge time gap when it is taken for तो उसमें नहीं.
सर हाँ अब तो क्लियर कट आ गया है कौन सी पॉइजनिंग लवाज करने वाली है कौन सी नहीं करने वाली. क्लियर कट आ गया. तो जो अब तो ये सिखाना है इमरजेंसी फिजिशियन को कि मुझे किसमें लवाज नहीं करना. पहले तो वो सब में ही करते थे, एक हैबिट जैसा अभी डिस्कशन हुआ था. लेकिन अब ये बिल्कुल डेजिग्नेटेड होना चाहिए कि अगर ऐसा सस्पिशन है एग्जैक्टली सर. तो मुझे नहीं लगता कि अब कोई ऐसा बहुत ज़्यादा करता है. और बाकी अमाउंट वगैरह हम सारा असेस कर ही लेते हैं. और पेशेंट वैसे भी सर वॉमिटिंग करता ही हुआ आता हुआ है. वो नेसेसरी पुटिंग अवे पेशेंट में उसको डालना और पकड़ना और कैरोसिन में भी हमारे ट्यूब डाले बैठे होते हैं. कोई भी पेशेंट है उसमें ट्यूब डाले बैठे होते हैं. सब कहीं बैठे होते हैं. लिक्विड जनरली एलिए से क्रॉस कर ही जाता है. जितना भी फिनॉल विनॉल पी के आते हैं सारे लोग. एक जो हॉस्पिटल में सबसे ज़्यादा ऑपियोइड हमारे इंडिया में मिलता है वो ओटी पर्सन्स में देखने को मिला गया है.
ओवर कंजम्पशन ऑफ फेंटानिल। वो एक दो स्टाफ गिरा मिलता है जो बड़ी ओटी होती है, जिनकी बड़ी ओटी है, उसमें एक दो स्टाफ तो पॉइजनिंग करके इमरजेंसी में आ ही जाए। इट्स पॉसिबिलिटी विद द ओपियोइड पॉइजनिंग। यस सर, जिसको इजीली अवेलेबल है सर, इजीली अवेलेबल दो ही जगह होती है, इधर ओटी और
और आप उसे बहुत सस्ता आप नलोक्सोन अपने फार्मासिस्ट को कहिए, आपको बहुत आसानी से वो ला के रख सकता है और कोई नुकसान नहीं है कि आप अपने डिपार्टमेंटल अलमीरा में 2 एम्पूल फिक्स करा के रखें। और पूरा 400 मत दीजिए, डॉक्टर ने बता दिया कि उसके अपने बहुत लोग। आई ऑलवेज प्रेफर टू डाइल्यूट इट टू 10 ml एंड देन एक करके देते रहिए जब तक रेस्पॉन्स आता है, एंड देन कीप ए वॉच कि वो दोबारा वापस। एक छोटा सा अप्रोच देता हूँ आपको। हम कल से बात कर रहे हैं कि टीम रखनी है, रोल्स रखने हैं, तो एक छोटा सा अप्रोच और देता हूँ। फॉलो दैट फॉर फ्रॉम SCCM इन ऑल द क्रिटिकल सिचुएशंस। एक अप्लाई एज अ अप्रोच डायरेक्ट। व्हाट इज डायरेक्ट? व्हाट कैन बी डायरेक्ट?
कम्युनिकेशन करना।
ओके,
Like you can ask me to do what?
direct is derived from D for detection, I for intervention, R for reassessment, DIR. Okay, अब क्या बचा? ECT is और क्या चाहिए टीम को अच्छा चलाने के लिए?
C तो कम्युनिकेशन है।
अब कम्युनिकेशन तो यहाँ हो रहा था, उसमें क्या कमी? So now what we need is effective communication. So DIR, EC is effective communication, and then P should be team. Now how I divide it? We take this patient only, जिसकी अभी हमने बात करी। पहला क्या था? D. हमने क्या डिटेक्ट किया? आपने प्राइमरी असेसमेंट किया, आपको लगा कि इसने कुछ खाया होगा, आपने क्या डिटेक्ट किया? उसका रेस्पिरेटरी रेट डिटेक्ट किया, आपने उसका BCS देखा, आपने पिन पॉइंट पे आए, आपने फटाफट सोचा कि ये किसी तरह का ओपियोइड है, डिटेक्शन हो गया। इंटरवेंशन क्या था हमारा? नलोक्सोन से पहले आपने ABCD किया, आपने ऑक्सीजन गिरा पोजीशन की जो बात थी वो किया, और आपने नलोक्सोन, ठीक है, आपने नलोक्सोन दे दिया। नाउ व्हाट कम्स नेक्स्ट? रीअसेस योर पेशेंट अगेन कि मैंने जो इंटरवेंशन किया उससे क्या फायदा हुआ या नहीं। हमारे रीअसेसमेंट में कहाँ जा रहा था? उठ ही नहीं रहा है, तो हम नाउ वी नीड टू थिंक ऑफ दवाई थी, गई या नहीं गई कितनी देर हो गई, इतनी देर में इफेक्ट मिल जाना चाहिए था। आई नीड टू रिपीट और नॉट, डू आई नीड टू थिंक अबाउट सम अदर ड्रग और आई नीड टू थिंक अबाउट सम अदर। So DIR, then comes effective communication. अब यहाँ effective communication कहाँ चाहिए? Okay, so जो मेरी टीम थी 5 लोगों की, उनके बीच में चाहिए। उसके आगे I always think of the effective communication। E और C कभी अकेले में काम नहीं करते। E और C हमेशा काम करते हैं जब आप अपनी टीम को लेके चलो। और टीम इसमें मुझे क्या चाहिए? Look at the holistic now. Who all are going to be involved in this patient? Who all are going to be involved in this patient? Okay, one is family। एक हमारी जो मेरी 5 की टीम थी, एक फैमिली हो गई। और कौन चाहिए मुझे? तो अभी सोया बात करते और कौन इन्वॉल्व होने वाला है इसमें? ना जब हमने डीपेट की बात करी, सबसे पहले क्या चीज़ आई? मैं अगली बार ना और जल्दी रिपोर्ट्स मंगाऊंगा। हाँ, रिपोर्ट लैब जल्दी तो तब मिलेगी ना जब आप लैब से बात करोगे। I got a patient, I am suspecting something, I want to send the sample। अगर मेरी लैब को पता हो कि जी ऐसा ये सैंपल है और अगर मैं जल्दी दूंगा तो उन्हें मदद मिलेगी, आपको लैब हमेशा जल्दी देगी। नहीं तो उसमें आएगा, जब वो उठेगा, जब वो करेगा, उसके बाद जब उसने देखना है वो तब साइन करेगा और वो डेस्क पे छोड़ देगा, आके ले जाओ।
और सर्जन
अभी आपने बताया होगा तो वहाँ से कॉल बैक आएगा, आपने सैंपल भेजा था, उसमें ये मिल रहा है और कुछ करना है क्या? दे आर ऑल्सो वेरी नाइस। वो आपको हमेशा ये पूछते हैं और कुछ देखना है क्या, क्योंकि सैंपल है अभी मेरे पास। देन व्हाट एल्स आई नीड टू कम्युनिकेट। रेडियोलॉजी चाहिए थी, किसी ने बीच में रेडियोलॉजी की बात करी थी। यू नीड टू टेल द रेडियोलॉजी। अनलेस यू टेल द रेडियोलॉजी आई हैव अ पेशेंट, मुझे एमआर चाहिए, सीटी चाहिए, एक्सरे चाहिए, अल्ट्रासाउंड चाहिए, वो नहीं होगा। और क्या चाहिए किसी पेशेंट को?
अगर ये पेशेंट अगर ओपेड नहीं होता तो मोस्ट प्रोबेबली इसका सीटी हेड कराना पड़ता है,
सीटी हेड कराना पड़ता है
क्योंकि अनकॉन्शियस है।
तो प्लान करना पड़ेगा। प्लान करके कम्युनिकेट करके तो रखेंगे। फिर उसके बाद मुझे क्या चाहिए? आईसीयू। अभी ये घर तो नहीं जाएगा, जब भी जाएगा तो घर तो नहीं जाएगा, कहीं तो एडमिट करोगे। अगर मेरा रेट अभी भी डाउन है तो ये आईसीयू जाएगा। और अगर आपको लगता है बहुत ही अच्छा हो गया और मेरे वार्ड में मैं इसको 24/7 मॉनिटरिंग दे सकता हूँ, तो उस वाले वार्ड में प्रोबेबली एचडीयू भेज सकते हो। ठीक है, आईसीयू नहीं तो एचडीयू भेज सकते हो। तो वो कोई बात तो करेगा वहाँ बेड है या नहीं है। अगर बेड बन सकता है, आप कहोगे कि पेशेंट है, अभी तो आप मैनेज कर रहे हो, लेकिन फिर वो कोई शिफ्टेबल पेशेंट को बाहर भेज सकते हैं। आपको आधा घंटा 1 घंटा जब तक आपको मैनेज करना है तब तक उनको यू नीड टू कम्युनिकेट टू देम। ठीक है। अब सबसे मजेदार एक लास्ट बताओ कि एक कम्युनिकेशन रह गया अभी। साइकेट्री चाहिए, यस, सो साइकेट्री आल्सो। अभी साइकेट्री कुछ काम नहीं करेगा। साइकेट्री काम करेगा जब ये पूरा उठ जाएगा, ये मान लेगा कि जी मैं खाता हूँ, कहाँ से लाता हूँ, तब मुझे साइकेट्री चाहिए कि भाई जहाँ से लाता है वहाँ से लेना बंद कर दे, इसकी जगह ऐसे करते हैं, तुम्हें इसकी जरूरत नहीं है, तुम कुछ और कर सकते हैं। देन दे कैन टेक ओवर। ठीक है। एक और कम्युनिकेशन जिसके बिना ये जितने कम्युनिकेशन थे ये सारे जीरो होने वाले हैं। अटेंडेंट
ये सबको
डॉक्यूमेंट करना है तो वो टीम में बांटना था ना किसी ने। फैमिली से बात करना, डॉक्यूमेंटेशन किसी ने तो बांटना था ना। तो पार्ट है टीम के।
सिक्योरिटी पुलिस,
वो अगर पीआई और एमएलसी काट रहे हो तो बेस्ट बने। बहुत छोटी सी चीज बोलूंगा, इस सारी चीज में जो सबसे कमजोर कड़ी होती है ना, उसकी तरफ हम कभी ध्यान नहीं देते। क्या हमने सोचा कि सैंपल लेके कौन जाने वाला है? क्या आपने जीजे को लीव करके रखा कि अभी तो कहीं जाना नहीं, हिलना नहीं, क्योंकि वो जैसे ही मरीज घुसता देखा वो पिछले मरीज का कुछ लेकर निकल देगा। आपने कहा आईसीयू भेजने की बात करनी है, 1 घंटे बाद भेज के दिखाना, ना सिलेंडर मिलेगा ना जीजे मिलेगा और तो और ट्रॉली भी नहीं मिलेगी वहाँ। यू नीड टू हैव अ फुल टीम, और वो तभी आएगी जब सबको कम्युनिकेट करके हम वहाँ पे रखे होंगे। राइट, सो इट्स वेरी इंपॉर्टेंट टू पिक अप दोज थिंग्स जो कि मेरी सबसे कमजोर कड़ी होने वाली है। Involve them. Involve
a
everyone.
lot of manpower is involved and most of the hospitals are lagging in it. I think.
Sir, it's a part of training. Limited ICU setup.
ये आपको पता है ना मेरे पास कितने हैं। अगर आप ये कहो कि मेरे 10 पोस्टेड थे और उसमें से 2 खड़े हैं इसलिए मैं काम ज्यादा हो रहा। नाउ इट इज यू हु हैज टू डिवाइड कितने लोग हैं और उनमें मुझे कितना काम करना है, और उसको काम करने के लिए मैं क्या तरीका बनाऊंगा कि मेरा काम ये तेज होता जाएगा।
This patient also requires probably a chest X-ray. मतलब एक्सप्लेन तो कर ही सकता है, ऐसा पेशेंट हो सकता है हमारे आने से पहले एक्सपेक्ट कर गया, क्योंकि
It's most common actually.
मोबाइल
अच्छा ओके, एक केस और। चलो टीम, ड्यूटी टीम। Duty team. Good. Sapna, very nice. Mridul, yes.
Dr. Mohan.
Mohit. कौशल। यार सारे इकट्ठे डॉक्टर काम करोगे कैसे मरीज बचेगा?
मैंने जो कर दिया प्रशांत सर ने बोला दूसरे को मौका नहीं दे रहे, मैं हाथ खड़ा कर रहा हूँ
ये मैं जीडीए दे सकता हूँ, चाहिए? He is going to be very good. वो आपको बताता भी रहेगा कि आप कुछ मिस कर रहे हो।
मैं यहाँ खड़ा रहूँगा। इनफैक्ट एनालिसिस में बता रहा था यार, वो ऐसा नहीं हो रहा है।
सुनो करो ना, मैं वही तो कह रहा हूँ। यस, काउंट टीम, वर्किंग टीम आगे, बाकी सब 2 कदम पीछे। बन जाता नहीं है। We all are inborn leaders, ऐसे थोड़ी ही होता है।
सेल्फ प्रोक्लेम।
Okay, so now what we have is we have a VIP patient to your emergency. शहर के जाने माने बिजनेसमैन मल्होत्रा साहब और अपनी गाड़ी में पाए गए हैं और उनके पास एक कुछ स्मेली से लिक्विड की बोतल मिली है गाड़ी में, राइट, एंड ही हैज जस्ट बीन ब्रॉट टू योर इमरजेंसी बाय द ड्राइवर। मल्होत्रा साहब को बचाना आपकी जिम्मेदारी है। थोड़ी देर में सारा मीडिया आने वाला है।
लिक्विड की स्मेल कैसी है?
गंदी है।
पेशेंट आया पहले इनको रिस्पांस
करते रहो, बट बोलने
नाम
की
बताइए अपना?
सैचुरेशन वाइटल
आप एक काम करिए, आप एयरवे देखिए, आप कैबिनेट सैंपल लीजिए,
डॉक्यूमेंटेशन
एक दो बार देते बस।
नाम बताइए। नाम बताइए। बोल रहे हैं
क्या कर रहे हो?
बोल रहे हैं
बोल रहे हैं। क्या कर रहे हो?
नाम क्या आपका?
क्या कर रहे हो आप मेरा?
क्या क्या पिए दादा जी?
क्या कर रहे हो आप मेरा?
सर ऑक्सीजन डाउन जा रही है, ऑक्सीजन लगा दें इनको।
लगा दीजिए। ऑक्सीजन लगाइए। जीभ निकालिए बाहर।
क्या कर रहे हो?
जीभ निकालिए।
कर क्या रहे हो मेरा?
क्या हुआ आपको?
आपका इलाज कर रहे हैं भाई, इलाज कर रहे हैं आपका।
क्यों कर रहे हो?
बोल रहे हैं ना, पेशेंट बोल रहे हैं, कंफ्यूजिंग है।
आपकी कंडीशन खराब है, आप गाड़ी में खराब है।
हाँ तो छोड़ दो।
बीपी कितना है?
बीपी साइनस
100 RBS की करनी है।
आरबीएस करते हैं।
मैम 120 है सुबह के।
ठीक है।
फ्लूइड अटैच करिए, बोलस दीजिए।
500 ml बोलस।
ऑक्सीजन लगा रखी है। बाकी इसकी जो बोतल थी वो बोतल लाए हो आप?
फेंक दी मैंने गाड़ी, वहीं फेंक दी मैंने तो। साहब को लेके मैं तो जल्दी से आ गया।
चेंज करा रहे हैं, कपड़े चेंज
कपड़े
करा रहे हैं।
कपड़े चेंज कराओ, उसको वो करो स्पिनिंग।
कपड़ों में ये 2 महक है।
तुरंत एबीसी की रिपोर्ट तुरंत करवा के लेके आएंगे।
बोल दे सर एबीसी के लिए क्या हो सकता है?
गाड़ी के ओपी पर ड्रिंक
लिक्विड है।
लिक्विड है, अल्कोहल हो सकता है।
अल्कोहल इंटॉक्सिकेशन कंफ्यूजिंग है तो लाल लिक्विड
सैचुरेशन
गंदा सा है, बहुत बदबू है।
एबीजी में क्या पूछा ना?
एबीसी रिपोर्ट
अभी कहीं आ गई।
फ्लूइड दीजिए फटाफट।
सर 500
1000 चला गया।
नॉरेट स्टार्ट करना सर।
दो यूनिट
नॉरेट स्टार्ट कीजिए।
नोट बना लो।
ईसीजी निकालनी पड़ेगी, टैक्सी भी तो हो रहा है।
नॉरेड स्टार्ट
ईसीजी निकालने से पहले
ऑक्सीजन लगाया भाई।
ऑक्सीजन कनेक्ट है सर, ईबीटी की रिपोर्ट आनी है।
अब अगर एसिडोसिस है,
Blood gas is 7.1 pH, lactate of 6, bicarbonate of 9, and CO2 is 56 with O2 of
सोडा बाइकार देना पड़ेगा 100
स्टेट में तो
100 ml सोडा बाइकार and start an infusion of 20 ml per hour.
नॉरेड कितने में चलाना है तो बताया नहीं। इन्फ्यूजन बनाना होता है।
गैस्ट्रिक का बात तो कॉन्टेंट लिखित है।
नॉरेड चालू किया आपने, नॉरेड चालू किया।
सर रेट कितने में करना है?
20 ml का सर, दूसरा कैमरा डाल दे रहा हूँ।
20 में चलाना।
एक कैमरा और ले लीजिए।
सर डाल दिया एक कैमरा।
डॉक्टर साहब अभी डीसी साहब आ रहे हैं, खबर पहुंच गई है मल्होत्रा साहब की।
एक इन्वेजिव आर्टेरियल लाइन ले लीजिए।
जल्दी मैंने नॉर्मल पर इंफ्यूजन बढ़ा दीजिए, इसको फास्ट करना पड़ेगा।
जो करना है जल्दी कर लो, अभी डीसी साहब आ रहे हैं।
सर पढ़ नहीं रही आर्टेरियल लाइन, बीपी बहुत कम है।
डीसी साहब आ रहे हैं, ऑफिस से निकलनी है, सारे आ रहे हैं अभी।
सोडा बाइकार
और 100 ml पर आवर पे इन्फ्यूजन कर दीजिए। 100 ml पर आवर पे इन्फ्यूजन।
आरबीएस कितना है?
120 बताया था।
इलेक्ट्रोलाइट
ब्लड शुगर कितना किया था? 120 किया था।
सर इलेक्ट्रोलाइट लेवल, सोडियम, पोटेशियम, कैल्शियम
भेजा है, सैंपल दो, भिजवा देते हैं।
पोटेशियम बढ़ा हुआ।
एबीजी में आया होगा।
एबीजी में नहीं आया।
आइस पैक हो रहा है।
छोड़ दो बस मुझे।
ऐसे नहीं छोड़ सकते हैं, और करना पड़ेगा मैनेज। वी हैव टू मैनेज।
पेशेंट के घर वालों को बताओ कि बहुत सिक है पेशेंट।
घर वाले अवेलेबल नहीं है।
घर वाले कहाँ, ड्राइवर ने छोड़ा है, डीसी साहब को बता दिया है, आपका डीएम आ रहा है अभी उठ के मल्होत्रा साहब के लिए। टाइम ज़्यादा नहीं है आपके पास।
कंटिन्यू इंफ्यूजन में रहेगा 8.2%।
नॉरेड चल रहा है, लाइन चेक कर लो।
अभी 12 पे रखा पड़ा है।
तो लाइन डाल लेते हैं।
बैक ऑपरेशन स्टार्ट कर दो सर।
100%
तो नॉरेड बीपी तो बढ़ेगा ना, टैक्सी कर देना।
लाइफ सल्फास हो इसमें।
टैक्सी के लिए ऑर्डर दे दो।
फ्लैट लाइन होने जा रहा है।
इंटीग्रेट करना पड़ेगा। इंटीग्रेट करें।
देखो इसी चीज
इंटीग्रेट करिए फटाफट।
कर दिया, ए पे सिक्योर हो गया।
शॉक लोग क्या मिस कर रहे हैं?
बीपी नहीं बढ़ रहा सर इसका।
नॉरेड भी कर दिया है, कर रहे हैं।
बीपी कम हो गया सर इसका।
देना पड़ेगा।
एरिथमिया हो रही है।
सल्फास पोइजन डालने की स्मेल है, मेटाबॉलिक एसिडोसिस
सर पेशेंट का बीपी हो गया।
ऑल क्लियर कौन बोलेगा?
आई क्लियर तो बोल दो। कितना चूल देना?
200 चूल देना है।
आई क्लियर और यू क्लियर और क्लियर बोल दो।
All clear?
All clear और all clear।
दे दो शॉट।
रिज्यूम CPR। रिज्यूम CPR।
6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
पेशेंट इंटुबेट हो गया।
हाँ, पेशेंट इंटुबेट है, हम दे रहे हैं इसको
SpO2 कम हो रही इसकी, सैचुरेशन और कम हो रही
100 है, FiO2 रखना।
100 है सर।
सल्फास पड़ी है इसमें।
इसको मैग्नीशियम सल्फेट और चला दीजिए।
मैग्नीशियम सल्फेट चलेगा उसको।
कितनी देना सर डोज?
1 ग्राम
6 ग्राम लोडिंग डोज।
6 ग्राम लोडिंग।
6 ग्राम लोडिंग डोज। स्टेट में
100 ml है।
हाँ, अभी 100 में उसमें 6 ग्राम जाएगी लोडिंग डोज। बाकी इसको सर
आरटी डाल के सोडा बाइकार्बोन बोलेगा तो
हार्ट रेट सर
ये लवास और सोडा बाइकार्ब उसके अंदर डाल के वो करना। आरटी डालते हैं,
आरटी डालनी पड़ेगी।
रिवाइव हो गया, आरटी डाल देते हैं। आरटी डल चुकी है, अब सोडा बाइकार्ब ले आओ, वो भी हो चुका है। अरे वैसे ही इसके लिए आरटी से लेंगे ना,
बीपी और डाउन हो रहा है।
सर बीपी
वो एब्जॉर्प्शन बंद करेगा।
नोरेट का रेट बढ़ा दीजिए थोड़ा ना।
कितने पे चल रहा है?
कितना चल रहा था इससे
15 पे
20 कर दीजिए।
तो
सर ऑक्सीजन डाउन जा रही है इसकी।
एक और
सक्शन कर दीजिए
सर बीपी भी लो जा रहा है इसका।
सर बीपी और लो चला गया। वैसो कर दिया स्टार्ट।
आईसीयू में
देखने आ रहा है।
आईसीयू रेफरेंस
आईसीयू टीम को इन्फॉर्म कर दो।
सर एमएलसीस की हमने करा दिया, इन्फॉर्म कर दिया है, पॉइजनिंग, सस्पेक्टेड पॉइजनिंग।
आईसीयू की जो बेड खाली
है
खाली है। वेंटिलेटर पे करते हैं। वेंटिलेटर
आप जैसे हटा दे तो वेंटी भी सपोर्ट है।
बेस्ट पर्सन ऐड करते हैं नॉलेज के
अटेंडेंट को इन्फॉर्म कर दो आपके पेशेंट को आईसीयू में शिफ्ट कर रहे हैं।
बेस्ट पर्सन ऐड कर दिया है।
जीडीए खड़ा,
अटेंडेंट कोई नहीं आ रहा मैडम, अटेंडेंट कोई नहीं है।
इनके साथ जो आए हैं जो उनको लेके आए उनको इन्फॉर्म कर
ड्राइवर
दो।
गया निकल लिया बाहर। ड्राइवर इतनी देर रुका रहेगा आपको।
इसका मंजूर कर दिया।
क्या करेंगे? बीपी तो बढ़ी नहीं रहा सर।
प्रेसिडेंट के लिए लिया नहीं लिया।
बीपी रिपीट चेक कीजिए।
वैसोप्रेशन के बाद
बीपी बढ़ा दो वैसोप्रेशन देकर स्टार्ट कर दिया। वैसोप्रेशन चला दिया। हार्ट रेट सर वैसोप्रेशन
अरे चला गया, हो गया कनेक्ट।
बीपी बढ़ा दो सर अब।
चला
SPO2 हो रही पर इसके सर लो।
ड्राइवर चला गया।
सैचुरेशन गई, सैचुरेशन नहीं आ रही। जरा पे स्ट्रेट लाइन एट्रोपिन भी दे दो उसको।
अरे
एडीआर लगाओ। दे दिया सर।
प्रोपेन दे दिया ना।
एट्रोपिन दे दिया, एडीआर भी दे दिया। गया सैचुरेशन नहीं आ रही। ना ना सर मेरे से क्या लगा?
आराम से वापस।
सर रिपीट करें एडीआर।
एडीआर रिपीट करना पड़ेगा। नॉलेज जैसे प्लस। चलो लेट्स हम करते हैं क्या? हमारे को ये बताओ कि हमने ऐसा क्या हुआ जिससे हमें किसी के आने से करना You may not be able to say. There is a time for action where it can react, where it cannot react. So that's not my question. So my first question which comes, how do you feel?
Exhaustion.
Exhaustion. Okay, I can understand that. No, how do you feel? How do you feel at the next?
Appreciate it.
Our team did well, but we feel sad for the patient.
Sorry, feeling क्या है? टीम ने अच्छा किया, पेशेंट नहीं बचा. What's there in your mind? हॉस्पिटल में है, पेशेंट मैनेजमेंट है, ऐसा कुछ नहीं कभी करना है कि आपको उसको गिल्ट पड़े. Never ever think about it कि कोई गिल्ट. जो आप गिल्ट वर्ड लाना चाहते हो, मैं उस वर्ड को दूसरी तरफ लेके जाना चाहता हूँ. What are the things you would like to do differently in same situation next time? Before that, let us talk something good. क्या चीजें हैं जो इस टीम ने इस पेशेंट को मैनेज करने में अच्छी की? बहुत अच्छी, बहुत अच्छी. What are those things? What are those things? Work distribution. Okay. So क्या क्या work distribution था?
So जैसे ये सैंपल ले लेते हैं, लाइन मैनेजमेंट फ्लूइड एंड
और क्या काम की जरूरत थी? क्या इन 3 काम से मेरे सारे काम मरीज की जो जरूरत होगी वो हो जाएगी? तो मुकर गई नहीं किया कि मैडम को किसी ने कहा ही, आई एम विटनेस टू इट, किसी ने मैडम को कहा ही नहीं कि आपका ये काम. मैडम के पास टाइम था, मैं आपकी फीलिंग को ले रहा हूँ कि मैडम के पास टाइम था, वो ऐसी जगह खड़े थे कि वो सब चीज़ें देख रहे थे, उन्हें पता था, वो नोट कर सकते थे, बट मैडम को किसी ने दिया नहीं. और क्या अच्छा किया? बहुत अच्छी की, बहुत सारी चीज़ें बहुत अच्छी की. क्या
टाइमली पता चल पाए कि कौन किस चीज़ का इंटरवेंशन.
Okay, you thought about this very early. That's wonderful. आप जल्दी से अल्फोस पे पहुँचे. ठीक है, अल्फोस से पहले आपने सबसे अच्छी चीज़ करी थी कि आपने एयरवे को देखा. एयरवे देखते ही आपने उसको ऑक्सीजन दिया था. So you did A and B very fast, and C was also done very fast. And without being instructed, he put up a cannula and fluid as well. Yes, that was very good. But what it would have been better कि हमारा वो डिसीजन टीम लीडर से आता कि तुम सी संभालो, या तो ऐसे काम होता या ये काम होता कि लेट अस सिक्योर है आईवी, और जब आईवी सिक्योर करते हैं तो उसमें से मैंने सैंपल भी उसी में से ले लेना, एंड देन आई गिव द फ्लूइड्स एंड ड्रग्स टू समवन. सो जो काम बहुत अच्छा हुआ, लेकिन उसमें थोड़ा सा ये था कि वो शायद इंडिपेंडेंट हुआ, टीम लीडर को नहीं पता था कि वो है. और ऐसा नहीं, कभी ऐसा नहीं मानना है कि जो टीम लीडर है उसे सब कुछ मालूम होगा उन रिफ्लेक्सेस में जो सिचुएशन सब होगी. टीम की ये जिम्मेदारी है कि आप उस समय टीम लीडर को बोलिए, सर इसने बोला था, मुझे नहीं पता, टीम लीडर ने सुने, एक कैनुला और लगा लूँ, मैं लगा ले, राइट. सुनाओ, जितनी मेरे टीम मेंबर की जिम्मेदारी है इतनी मेरी टीम लीडर की भी जिम्मेदारी है. यस, वेरी नाइस पॉइंट, वी वर लैकिंग ऑन दैट. Let us put another cannula and start one more fluid. So, unless हमारी बात close loop में आती है, वो effective नहीं होती, right? So that was wonderful. So I would say that this was the most active team member जिसने कि line तेजी से पिकअप किया. But मुझे अच्छा नहीं लगा टीम ने वो टीम के अप्रिशिएट करने की बात है कि यस वी आर मेकिंग ऑन दैट. हम चेक और करूँगा एक और फ्लूइड लगा देंगे, हम थोड़ा सा फ्लूइड लगेंगे, थोड़ा सा हम उसको, क्योंकि जब आप टीम में काम कर रहे हैं तो 5 मेंबर एक ही लेवल पे काम करते हैं, कोई फिर फर्क नहीं होता. टीम लीडर इसलिए होता है कि सारी चीज़ें एक तरफ से कलेक्टिव होकर हों, एफएसआर ना हो. और उसकी सबसे बड़ी ज़रूरत ये होती है कि आपने इंजीनियरिंग देना डिसाइड किया था, 3 लोगों ने इंजीनियरिंग लगाई,
double.
So I just need some channel कि एड्रेनलिन जाएगा तो इसी चैनल से जाएगा, यानी कि टीम लीडर के ही चैनल से जाएगा, जिससे कि वो अगर एक देनी थी तो एक ही लगेगी। ऐसा नहीं हो कि तीनों भाग गए और 3 जन वहाँ से कम हो गए पहले और उसके बाद 3 वापस आए और 3 एड्रेनलिन मेरे को एक चैनल चाहिए फिल्टर कर। तो टीम लीडर का काम फिल्ट्रेशन का। टीम लीडर का काम कहीं से भी ऐसा नहीं है कि वो सबसे ज़्यादा डिसीजन मेकिंग मेरी पूरी टीम। All those ideas have to come. They go to the team leader, filters there, and then come out as a decision. Okay. So what else you think now कि हम इसको अगली बार कुछ अलग करेंगे और आउटकम में कुछ बेहतर होगा? इस मैनेजमेंट में अगर इसमें जो मैं डायरेक्ट कह रहा था डायरेक्ट लगाएंगे तो उसमें कहाँ कहाँ चेंजेस की जरूरत है?
डिटेक्शन में
वंडरफुल। तो हमें जो भी हमने किया उसको रीअसेस करके हमें ये देखना है कि हमारे को जो करा उससे फ़ायदा हुआ तो आगे क्या करना है, नहीं हुआ तो हमें क्या रिव्यू करना है।
I think soda backup and maintenance we somebody told that you mentioned. But I
Okay,
guess
that's great. Wonderful. Which was the team managing this patient? Which was the team managing this patient? Not the problem. Your team थी इसको मैनेज कर रही। Okay, 1, 2, 3, 4, 5. Who gave a decision for soda backup? Who gave the decision for soda backup? None of you 5 gave the decision for soda backup. 5 में से किसी ने नहीं बोला। 5 में से किसी ने नहीं बोला। मैं रिकॉर्डिंग दिखा दूंगा।
थोड़ा भाई का लग चुका है।
बोला था 100 ml
स्टेटमेंट बोला था।
कोई और बोल के गया था इन 5 के अलावा। रिकॉर्डिंग निकलवाओ।
लग चुका
My all these meetings are with recording.
ये बोला
That has both positive and negative points for management.
Yes, sir.
You got an idea from a 6th person. Absolutely right, absolutely implementable. But it has to be assimilated to the team and then implemented.
चार्ट पे जाएगा ही नहीं ना।
मुझे एक बात बताइए, आप टीम, ये आपका मरीज, मैं तो दूसरा मरीज देखने आया था।
नेक्स्ट यूनिट
मैंने मुड़ के देखा, मुझे क्या पता है पोस्ट का है, मुझे लगा ट्रॉमा का मरीज आया हो, मुझे लगा ट्रॉमा का मरीज है, मैं कुछ बोला चला गया। Whether you are accepting or not, it has to be your decision. So team has to accept it. Team has to accept. Yes, right. Okay, we are suspecting alcohol. Our patient is going down. There is a fall in pH. So we should put up start compensating for the pH. Let us put up soda. कोई आके मेरे को बोल के चला जाएगा और मेरे मरीज को कुछ मिल जाएगा, मैं I just do not accept it.
But it could be another unit doctor is just telling.
No, but because उसे क्या पता चलेगा? टीम डील तो ये टीम करती है ना, ऐसे नहीं किसी को। वो जो आ रहा है या तो वो टीम का पार्ट है या उसका आइडिया हमने असेस कर दिया और हमने फिर टीम नहीं बची, फिर ये मेरा है काम है। जो आया वो अपनी मर्जी से कुछ करके चला गया, ऐसे नहीं होगा। जो भी आइडिया आया वो आइडिया टीम ने लिया, टीम लीडर ने एक्सेप्ट किया, टीम ने डिस्कस किया, वी एग्री टू इट, वी इम्प्लीमेंट इट। अब कौन इम्प्लीमेंट करेगा वो हमारा आपस का मामला है कि इसको ऐसे जोड़ते हैं, वी डू इट। और क्या अगली बार कुछ बेहतर करेंगे। कमिंग बैक टू द क्लिनिकल केस मैनेजमेंट ऑफ अल्फॉस, तो अल्फॉस में कहाँ तक जा सकते हैं? अल्फॉस में हो क्या
मेटाबॉलिक
और वही सारे सिस्टम को खराब करते जा रहे हैं। तो उसके लिए 1-2 लाख की सोडा पाइप। दूसरा हमने क्या सोचना है, CRR की सोचनी है, किस फॉर्म में अवेलेबल है, कहाँ अवेलेबल है, कैसे प्लान करनी है, so we need to think about it. So that comes as decision and then communication and then उसमें और क्या हम झगड़े में लगे रहे हैं कि मुझे ब्लड गैस चाहिए, मुझे ब्लड गैस चाहिए। आज की डेट में ब्लड गैस से पहले तो वहाँ प्रोब रख के देखो ना कार्डियक फंक्शन मेरा कितना बचा है, कितना नहीं बचा है, राइट। और ऑब्वियसली मैं नहीं कर सकता था, 5 जनों में नहीं था कोई भी इनको कर सकता। ये पीछे वो ऊपर बैठा ड्यूटी बुलाओ ना जो कर I need to involve eco will go serial eco। अभी आया है तो 40 मिलेगा, आधा घंटे बाद 30 हो जाएगा, 2 घंटे बाद तो मालूम पड़ेगा कि 10-15 पे आ गया इतनी देर में। And probably that was the reason we were keeping down, BP feel burden भी and now और क्या इसमें हेल्थ में और क्या सोच सकते हैं जो आजकल बहुत अपकमिंग ECMO, ठीक है। तो people are putting upon ECMO और उस ECMO के लिए people are putting up these patients on extended CPR before taking up for ECMO। So इतनी जल्दी से भी छोड़ भी नहीं देना है patient। मैंने कहा छोड़ दो, सब छोड़ के बैठे खुश हो राइट। प्लान क्या है? That plan has to come out from the team and then that plan has to be communicated. Someone has to communicate it, मेरे को इको चाहिए, इको रखना है यहाँ पे, someone has to be communicated, इसको मुझे इसको तुरंत डायलिसिस लगाना है, वो मेरा प्लान करो, उसकी तैयारी दो, सर्किट दो, मशीन लाओ, कहाँ शिफ्ट करूँगा, अगर मैं ICU में करना चाहता हूँ तो ICU को बोलो, आई शिफ्ट द पेशेंट टू ICU एंड देन वहाँ पे मैं ऐसे एक लाइन कह रहा हूँ कि तुम्हारे शहर का सबसे बड़ा बिजनेस तो कोई तुम्हारे पास लिमिटेशन नहीं थी तो उसको क्यों अपने पास रखी? स्टार्ट थिंकिंग ऑफ वेदर आई एम गोइंग टू कीप दिस पेशेंट, व्हाट वुड बी माय लिमिटेशंस इन माय सेटअप, व्हाट आर द सिचुएशंस दिस पेशेंट शुड बी इन some of the very high paying centers or to be airlifted or something or something. So मेरे पास मरीज आया, मेरी जिम्मेदारी है उसका आउटकम बेहतर सोचना। मेरी जिम्मेदारी ये नहीं है कि जब तक मरेगा नहीं मेरे पास ही रहेगा, कतई मेरी जिम्मेदारी। मेरी क्या लिमिटेशंस हैं, मैं उसको क्या क्या दे सकता हूँ और मैं उसको क्या क्या ऑप्शंस दे सकता हूँ, मेरे को वो सारी चीज़ें ऑफर करनी है। कहाँ जाना पेशेंट को, मुझे ECMO सेंटर पे करना है, मुझे अपने पास रखना है तो मुझे रीनल रिप्लेसमेंट क्या देना है, मुझे बाइकाप कहाँ लेना है, कितना देना है, कितना इन्फ्यूजन देना है, रखूँगा तो मैं मॉनिटरिंग कैसे रखना चाहता हूँ, मैं सीरियल इको रखना चाहता हूँ, कार्डियक फंक्शन पे नज़र रखना चाहता हूँ कि मेरा कार्डियक फंक्शन कैसे कैसे ब्लॉक हो रहा है या मेंटेन हो रहा है, देन मैं प्रोसीड। डायग्नोसिस किसी मरीज़ की इतनी मुश्किल नहीं है, जो डायग्नोसिस पता चल गई तो उसकी स्पेसिफिक एंटीबायोटिक, एंटीडोट, ट्रीटमेंट सब आपको मालूम है। जो दिक्कतें होती हैं वो दिक्कतें ये होती हैं कि जो एक कलेक्टिव डिसीजन चाहिए होता है लॉन्ग टर्म में, वहाँ पर दिक्कत होती है, कोई दिक्कत नहीं है।
ECMO if we communicate आपके हॉस्पिटल में नहीं है, then as you said rightly communicate करना, so they know because of ECMO they are shifting.
I need to tell that hospital plus the family or attendant कि भैया इसको देखो there is a mobility हमारे पास नहीं है, मेरे पास अच्छी नहीं है, but आज की डेट में हॉस्पिटल अगर कोई अपना बनाना चाहता है, आप करना चाहते हैं, खर्चा आपको देखना है, हॉस्पिटल देखना है। यहाँ पे नियरेस्ट जो है ये 3 सेंटर हैं जो ये कर सकते हैं, और वो कहता नहीं मेरे को यहाँ कराने ही नहीं बात मैं भी नहीं लेके बन जाए, ठीक है साहब हमारे पास 2 एयर एम्बुलेंस वाले हैं, उनसे आप संपर्क कर लो, आपको उठा के ले जा सकते हैं तो ले जाओ। But everything will come out from your team, हम क्या डिसीजन। So unless we all do that, we will not be successful in removing the guilt from ourselves and never keep a guilt. Never ever keep a guilt.
गार्लिक स्मेल
तो हमने जैसे सोडा
बिल्कुल
सर उसकी जो स्मेल होती है वो फॉस्फेट की वजह से फेसी हो रही है फॉस्फोरस की वजह से स्किन का फॉस्फोरस की वजह से उसमें फॉस्फेट
ये नहीं है ना
So wonderful, when as soon as he came, he started looking for the cardiac functions. Your patient is back. Congratulations for that. ये तो ये आपको बताएगा इसने क्या डाला?
आगे पेशेंट आ गया आपको देखो बाबूजी आगे बोलो आगे खोलो नहीं सुन
It is नहीं। आप किसके लिए ले रहे हैं? आप तो आप ले सकते हैं। आप नेफ्रोलॉजिस्ट को भेज के दोगे तो नहीं होगा। आप लगाओ ना, नहीं निकालूंगा बोलो। और कुछ कर भी नहीं निकालूंगा, फिर जा रहा है। आप लगा सभी का जो पेपर है वो यही है। CRIT काम करेगी, क्योंकि जब तक CRIT काम करेगी तब तक उड़ जाएगा। काम करेगा तो Thank you very much everyone. Anything you want to see with the patient or
from medical legal negligence point of view, many times done and not done. That is the biggest case.
Now, I cannot disclose the cases or names, but last couple of years I am part of NMC ethics committee. So I do all the referrals for UNMC complaints. जब तक complaint review होती है, there is no evidence. The only evidence is your documented case. There are cases जहाँ पे grossly दिखाई देता है यहाँ कुछ नहीं किया गया, फाइल में ऐसे लिखा हुआ होता है वो लोग वही करते हैं। There are instances where you feel कि नहीं सब कुछ ठीक बोल रहा है हुआ होगा, but there are gross gaps in the file. It might be in time. I'll give you one example. There was some mishap and it was under inquiry, and surgeon's notes say that a patient had his stroke at 7:30 and anesthetist notes say that it happened at 6:45, and nursing file says that 7:30 patient was in ward with all the vitals not that gives you the suspicion and then you just answer.
That's when I have seen this TPR reaching like half an hour they have to post. That's was finishing duty at 8 p.m. and at 7:30 she had made entry of 8 p.m. 8 बजे का एंट्री डाल के चला गया था बिटवीन 7:30 to 8 बजे और 8 बजे का उसको था कि 8 बजे निकलना है
Thank you everyone. Enjoy. Thank you sir. Thank you everyone.
Let's go for lunch.
Yes sir.
पूरा